Thank you, Dr. Lara. I think in the interest of time, we will get going here. My name is Dr. Ernie Kaninjing. I am with the African Behavioral Research Center. I'm also with Georgia College and Assistant Professor of Public Health. I'll be one of your facilitators for this session. I also have my colleague, Dr. Noreen. Noreen, can you please introduce yourself briefly before we dive into this?
Yes, thank you, Annie. I'm Noreen. I'm an associate professor in global public health at the University of York in the UK. As Annie said, I'll be jointly facilitating or moderating this session. Thank you.
All right, thank you so much. We have a lot of ground to cover this morning, as was eloquently laid out for us by Dr. Uche's talk earlier this morning. I think we can all agree that there is definitely an issue in terms of cancer drug access in low and medium income countries, particularly in sub-Saharan Africa. So definitely we do have a problem in terms of drug being accessible to patients who need them. So the question that we've been charged to do, first of all, who are some of the actors that are involved in terms of procurement or making sure that drugs are available and accessible? So we'll take this one at a time. We'll talk first about, maybe for 5 minutes, talk about who are the actors that are involved. And then next we'll talk about the environment, the systems, before we move on to the second question. So most of you are practicing in Africa. And this is something that you're dealing with on a day-to-day basis, trying to ensure that your patients get the most care to have a better health outcome. Who are some of the actors in terms of getting accessible drugs to patients? Unmute yourself. And don't you all speak at once? If you prefer to chat, you can do that. Noreen will keep an eye on the chat box. Who are some of the actors that are involved when we're talking about cancer drug access in terms of treating patients? Who are some of the players involved? And let me just do a quick check in. My colleagues in Abidjan, vous m'écoutez? Can you hear me in Abidjan? I can see them and they're muted. I'm hoping that they're being interpreted too. But who are some of the actors in terms of drug access in Africa? Any thoughts on that?
Can I just say, and perhaps another way of thinking about it is just thinking about the different levels that we had in the earlier presentation, to think about individuals, households, and communities, and at the health service delivery level, and also the health sector level, and the public policy level, and just to think about those, levels, and think about who is an actor in terms of ensuring drug access, cancer drug access in Africa.
Okay. Any comments?
So can I say something? If you ask who are the actors in access to drugs, it cuts across the entire chain, from the administrators to even the end users. Okay, so we look at the administrators from both government and the facility level. We look at the healthcare workers themselves, including the pharmacists. We look at the drug manufacturers. They're also a major actor in ensuring that there's access to cancer drugs in the continent, especially at the state level. And then we look at the vendors. So some of those distributors who interface between the manufacturers and then the end users. And the patients themselves, also the actors. So if you look at the actors, they cut across from the point of manufacturing these products to bringing it into the various countries, and then to the end users themselves. So each of these people have roles to play in ensuring access to cancer treatment.
Well put, Dr. Uche, thank you so much. And also, when you mention government, so we're talking like the Ministry of Health, is that correct?
Yes.
Okay.
Yes, and then the Ministry of Health and the hospital administrators also.
Both in the governmental sector, the private sector, and also individual clinics that are owned by folks who are not necessarily part of the government.
Yes.
Okay. So any other thoughts of some actors that were left out, the individual patients, even their loved ones too, who are, maybe helping them, the caregivers, talk about, healthcare workers working within the healthcare system, the drug manufacturers, distributors, and people who interface between the drug makers and the patients. Any other actors that were not mentioned? So let's move on and talk about the environment. So what is that environment like for those of you practicing in sub-Saharan Africa in terms of getting access to your patients? What is that environment like, that working environment like? So somebody had asked me to repeat the question. Again, the question is, what is the work environment like in terms of getting access of cancer drugs to your patients? What is that working environment like?
Can I chime in since nobody else is speaking?
Please go ahead.
Yes. So I work in a private center in Lagos, Nigeria. So the environment is very different from hospital to hospital, whether you go to a big teaching hospital or you're in a private center or you're in a general hospital in a smaller city. So in the private setting, it's all affordability. So you have a wide spectrum of individuals. Some people can afford even targeted therapy that is very expensive. Some people have struggles even affording generic chemotherapy. So there's just a wide spectrum that we see. Thank you.
So you're putting your finger there on the issue of, equity, equality, some can, others cannot.
Yes.
Okay. All right. Other thoughts about your, the work environment in which you're able to get access to cancer drugs or not able to get access to cancer drugs? All right, if we're not getting more comments on that, let's talk a little bit about the system constraints. What are some of the constraints within the system? What are some of the system constraints for those who are working in terms of trying to get access to drugs for their patients?
Well, I don't know whether other people are having difficulty unmuting themselves, because I'm sure some of the others who work in different settings can shed more light. In the private setting, there are many kind of vendors that are keen to provide drugs. The challenge is just affordability, but there are many companies there that are looking to sell their products. Again, the biggest challenge we have is affordability. I don't know what experiences are out there in terms of insurance coverage. Some people have insurance, but there's a cap on what the insurance covers, and we know that cancer drugs are very expensive, so it doesn't take much for the cap to be reached. So those are some of the challenges, but I think the companies are making a great effort in making these drugs available within the country. So
when you talk about insurance, what's the penetration rate? What percentage of your patients would you say have it, and what percentage does not have access to insurance?
I think the penetration is still low. I would say, just ballpark figure. I don't know whether I would say 20-25% of our patients have insurance. Some people come from a corporation. They work for, let's say, an oil company, or their family member works for an oil company. So that corporation just provides the care. But a lot of people pay out of pocket. Sometimes, relying on family members. Some of the family members are abroad, so it's challenging. We're trying to now study this in more detail to find out exactly what the figures are. But the penetration of insurance, I think, is still very low in our experience.
Okay. Abidjan, vous m'écoutez? They're all muted. I cannot tell if they're hearing or not. I don't get the signal from them. Any other experience about
Abidjan, nous sommes là.
OK, quel problème pour the drug de cancer? Ray? Ray,
En
are
fait,
you
c'est
there?
cette question-là même qu'il pose.
Is Ray there?
Allô?
Ray?
Hello?
Yeah, Ray.
La question, s'il vous plaît. La question,
Mais
s'il vous plaît.
Quel problème que vous rencontrez pour l'accès de drogue?
Quels sont les problèmes qu'on a par rapport à l'accès aux médicaments?
D'accord, donc justement, c'est sur ça qu'on est en train de débattre.
Justement, c'est sur ça qu'on est en train de débattre. Le professeur Omé, professeur anatomie-pathologiste au laboratoire central à Abidjan, était justement en train de parler de ce sujet-là. Donc, on va lui laisser la parole. Pour ça, allez-y.
Encore? Je n'écoute pas encore, monsieur.
Ils n'entendent pas bien. Ils n'entendent pas bien.
Plus en charge uniquement dans les CHU.
OK.
Mais un certain nombre de patients, comme on l'a constaté ici, il y a toute une stratification. Parce qu'il y a les travailleurs du public qui sont au niveau de la mutuelle, ils sont donc pris en charge par cette mutuelle pour les médicaments. Il y a les travailleurs du privé, du secteur privé, qui sont pris en charge par la CNPS. Et donc, ces assurances de ces travailleurs. Oui. Et puis, il y a une catégorie de gens qui ont les moyens de la conférence, qui ont leur assurance privée.
Okay. All right. He was cutting up there, but the gist was, there's a problem of access.
Les médicaments qui sont mis à disposition des juges ne sont pas
pratiquement insuffisants. Donc, la plupart des malades qui ne font pas partie de ces structures-là, des travailleurs publics qui sont couverts, des travailleurs du secteur privé qui sont couverts, et ceux qui ont les moyens pour avoir leur assurance, sont laissés pour compte.
Okay.
Et nous avons beaucoup de patients qui sont obligés de eux-mêmes assurer le coût des soins de santé. Peut-être que souvent, ils se limitent au traitement des chimios parce que s'il faut qu'ils voyagent, qu'ils aillent à l'extérieur, souvent certains, je crois qu'au Ghana, à côté ici, il y a une radiothérapie, d'autres doivent aller au Maghreb, d'autres doivent aller en Europe. Donc, le traitement est limité pour ceux-là parce que c'est juste le traitement des chimios qu'ils font. Et je peux dire que environ 70 à 60% des cancers ne sont pas couverts et n'ont pas le traitement adéquat, pas le traitement de soins adéquats.
Okay.
C'est ça qui pose le problème.
Okay.
C'est un grand nombre de patients
So he basically
qui n'a pas les soins de santé, qui n'a pas accès aux médicaments, donc au traitement complet. Voilà ce que je peux dire à peu près.
We'll move on.
Basically, le professeur Adoubi, il a un budget.
So basically, he echoed a lot of the comments we heard from Nigeria that some patients do have insurance coverage, others do not, and that there are different experiences. All right. In the interest of time, I'm concerned that we may not be able to address the second part of the question. So let's take a look at the second part of the questions that we were charged to take a look at this time. Can we identify one potential implementation challenge that is anticipated or experienced across many different settings? So can we identify one potential implementation challenge?
I will chime in here. I think a lot of programs that get released, there's a lot of bureaucracy involved. So I think that's an implementation challenge with many different programs. So are there going to be bureaucratic bottlenecks for patients to access this program? Obviously right now, for instance, in Nigeria, the chemotherapy ASEX program has been released in the private centers. We in the public sector, we in the private sector have been really pushing for it to be extended to us. It hasn't happened yet, but we're hopeful. Thank you.
Okay. So when you talk about the bottlenecks, can we be a little more specifics about that? What specific bottlenecks have you experienced that you think could be addressed to make access more easier for your patients?
Expérimenter dans un contexte pour ça, non? Je ne me trompe pas. Le défi pour nous, la prévention, hein? Puisqu'aujourd'hui, c'est les campagnes de sensibilisation, surtout l'exemple du cancer du sein. Par rapport aux années précédentes, cette année, par exemple, j'ai participé et on a eu plus de participants qu'avant parce qu'elles sont sensibilisées aujourd'hui à l'auto.
Yeah, we got cut off from there. Dr. Chami, can you complete your thoughts?
Well, yeah, I was saying anyway, and I was hoping that our colleagues in the public sector can speak about what they're experiencing. We have not had the opportunity yet to experience this access program. So I don't have any specifics to share right now about my own experience with the program.
Okay. All right. So
can I just, I'm sorry to come back to you again. I wondered because you were mentioning before that there's a program that has been implemented in the public sector, but for the private sector, you haven't been able to access that program. So perhaps, if you can, is it possible for you to elaborate what the problems, what the bottleneck has been that has not allowed you to access that program and provide those services as the private sector?
Yeah, we have been very excited for hearing about the program. I don't know, 4 years ago, then about 2 years ago, it was launched. In Nigeria, the Federal Ministry of Health is the anchor. They're the ones really organizing the program. And, rightfully so, they started out with the teaching hospitals. From the presentation we heard earlier, I think maybe 12 teaching hospitals, and then it's maybe extending to another 3 very soon. So I think they wanted to focus on the teaching hospitals and the government hospitals first. So we've been engaging all the different players, letting it be known that we're willing. At some point, we even volunteered to maybe be the coordinating center for the private sector. And I think we engage and get emails back and forth from time to time, but it hasn't happened yet. I don't think the federal government has approved for it to go to private hospitals yet. So that's the bottleneck.
Correct. And Dr. Uche said maybe he can clarify now or during our second session, but it strikes me more as an issue for scale up. They want to make sure that it works first with a smaller cohort before it gets scaled up. That's the way it strikes me, but Dr. Uche can clarify later when we either here on the second session.
Can I say something?
Yes, go ahead.
Well, I think one of the reasons why the federal government prioritized the teaching hospitals is the fact that to help with procurement in terms of the cost, it's assumed that patients or people that actually go to private facilities are looking at comfort and perhaps not really concerned with cost, which is why most of the patients are coming to the teaching hospital. We know that their cost is usually an issue. And again, they tend to the people in the rural settings and the more lower down in the socioeconomic scale. So I think perhaps that's maybe one of the reasons why they piloted with that. So having said that, in our experience with it at the teaching hospital, when the program initially piloted at my own institution last year, there was a stakeholder engagement. They came around and really tried to engage with all the stakeholders, but it perhaps did not do as well as they had expected. Again, maybe from some of the things that we learned earlier on, perhaps maybe some of the strategies that were used, it could have been a bit modified, but be that as it may, it did have some impact. We have, and again, one of the problems I think was the fact that some of the drugs that we routinely used were not on the program. So that has been rectified. And so we have more drugs now on the access program. So we have more of our patients benefiting. And then in terms of the retainership, having the patients coming back for more, it again speaks to the issue of funding and cost, because even though they offer it at a lower price than would have been, it's still not as low as most of the patients would like. Again, going back to what the first speaker talked about with the universal health coverage. So I think if it was much lower, I think the uptake will be more. But the federal government has again just recently launched a program, the Cancer Health Fund, where the really indigent ones are actually supported across the cancer care journey. So we feel that with that launch and the rollout, I think that we would be able to see more patients take up the cancer access program, and we'll also perhaps have more patients coming back again for their care on that program.
Just a quick follow-up, Dr. Amaka. You mentioned one thing. Remember, initially some of the drugs that you guys used was not on the list. Do you have a national list of essential drugs for cancer treatment?
So I think Dr. Uche will speak to that, but I think we're working on it at that time, because they were just launching and because it was a little bit of a challenge to get some of the companies to supply. So what the companies that agreed to be on the platform could supply was limited. But now with the initial rollout and the success, because again, I think that the companies were a bit skeptical in terms of ensuring that, they get return on their investments, So but I think that initial teething phase has passed. So we are able to, the Ministry of Health are able to get more of the pharmaceutical companies involved. And with that, they're able to provide more of what we actually need. But you're right. If we perhaps had a national drug formulary, I guess that may have helped to point them in the right direction. But again, I think part of the limitations was the fact that there were not many drug companies involved at the onset.
Okay, thank you.
Sorry, Dr. Lesbicon, if you can please rewind the question. I missed it. I just heard you. I got lost at some point. I don't see it. I can respond to it.
Dr. Eni, would you like to?
Yes, Dr. Uche, Dr. Amaka had mentioned that during the rollout at her teaching hospital, some of the drugs that they use in treating patients was not on that list. And my question to her was to find out if there is a national list of essential cancer drug in Nigeria, and how was that list established? Did they engage with stakeholders like teaching hospitals to make sure that the medications that they use for the patients were on that list?
Okay, thank you so much. we have the cancer medicines on the essential drug list. We also have relevant guidelines that we also follow in managing cancers in Nigeria, especially the harmonized NCCN guideline. That also informed the kind of drugs we looked out for. But that was not the determinant for the drugs on the program at the initial stage. The determinants were the manufacturers that were willing to be part of the program and what products do these manufacturers have. Okay, so when we started with Cipla and Pfizer. So irrespective of any other product that may be required by the cancer patients, if it's not manufactured by Cipla or Pfizer, we couldn't join the program at the initial stage. Okay, so when we started, of course, we learned along the lines, a lot of mistakes here and there, but like Tamaka said, when we have some success stories, some other manufacturers now joined. So today we have Roche and the entire Roche oncology products on the program. Now we have Novartis, the entire Novartis product on the program. We have Biocon and Viatris. And as we speak now, AstraZeneca has applied to join and the other manufacturers. So as they are joining with all their oncology products. So it is the products on the program are based on the manufacturers who are on the program and not necessarily the essential medicine list.
No, that makes sense. So you started small with some companies and the list has been broadened.
Exactly.
Okay.
Dr. Annie, just checking on time, right? Is our breakout session, the sessions are ending soon?
Yes, we're wrapping up. So we're just wrapping up. We heard the consensus about the cost to the patients as being a key aspect. That is an issue for the patients, particularly we heard that from Dr. Amaka, also heard that from Abidjan. They mentioned coverage. Some patients do have access to the drugs, but it's not equitable. Not everyone who needs it necessarily can afford it. So that to me was a key takeaway. Dr. Noreen, last thoughts before we wrap up?
Yes, and I think that was the major thing, that constraint that came out. I think there was an issue as well around how the differences between the private and the public sector, in terms of the private sector having to, meeting bureaucracies in terms of if they want to also to provide the service and increase access. But I think that was explained, really well by Dr. Amaka. In terms of, the government prioritizing the public sector because, to ensure equitable access, particularly for the poor. Thank you.
All right, I think our first session is done. During the second breakout session, please make sure you stay within this group. We'll continue the conversation in breakout session 2. All right, I don't know if we stay here. I think we're in the main room. I think the others are joining us.
Okay, Dr. Ene.
Yes.
We are back in the main room.
Okay, it's you now, Dr. Ladeibo. Yes, we're done with our breakout session.
Okay, so we want to welcome everyone back from the breakout session. We want to go to the next session now. We are some few minutes behind. We have some speakers that will be taking the next session. The next session we'll be talking about, are we already applying the elements of implementation science in projects in Africa? We'll be looking at a real life example. And Dr. Jemima Kamano and Miriam Kedman will be taking us through that session. Also, afterwards, we'll look at why implementation science for cancer prevention and control in Africa. We'll be connecting implementation science to real life challenges. And Dr. David Chambers is on ground to take us through that. And after then, we were looking at making sense of implementation science. We'll be looking at some theories, models, and frameworks. And Dr. Ramaswamy and Dr. Echizona Ezonolu, I'm sorry if I pronounce the name wrongly, they'll be taking us through the frameworks, the theories, and models in implementation science. So right now, I want to hand over the main room to Dr. Jemima Kamano.
Okay, thank you so much, and it's a pleasure to join you, albeit a little bit earlier than I was planning. So what I'd like to do is tie into the wonderful discussion you've already had around why implementation is so important, and really try and help to make the case why implementation science would be a useful endeavor to do more work in. Of course, I'm setting up for wonderful speakers to follow who are going to delve much more into the models, the frameworks, and the designs. But really just wanted to walk you through, from our research perspective, how we get to implementation science, why we think it's important, and talk a little bit about some of the both areas in which we've been investing, and then opportunities to really think through where we can go together and how we can learn as much as possible from all of your wonderful work in Africa. So very quickly, going to talk a little bit about what implementation science is, how it relates to cancer care, some of those activities, and move on to opportunities and a few resources that might be helpful. So from the research perspective, we're often thinking very linearly. You see at the top, this is roughly that sort of drug development pathway from the idea and the concept onto our phase 3 trials. And we sort of assume that at each stage, we know as much as we need to know to move to the next stage. But then, of course, you see that our work does not end with a phase 3 trial. It really needs to make sure that everyone who could benefit from these treatments, from these other programs, actually do so, that we follow through on the promise of discovery. If you look at the bottom and just roughly again see this somewhat linear cancer research continuum from basic biology on through to trying to make a public health impact. Again, too often we're not really thinking about where we're heading in the long run, but we're just thinking about isolating what can we learn about biology, what can we learn about prevention, what can we learn about detection, diagnosis, treatment, public health. So the idea being that the linear model has done a lot for us, but that there are some limitations if our ultimate goal is to try and optimize population health. And so another way in which we think linearly is this idea of what happens once our research is completed. And this comes now 21 years ago from a study that Andy Bayless and Sue Boren did in 2000, where they said, let's assume that the end point of our studies is the publication, right? And so what you can see down the middle of this graph is we complete our original research, we submit for publication, it's accepted, hopefully, it's published, it makes its way into our databases, and ultimately is considered in terms of our reviews, our guidelines, textbooks, and then gets implemented. On the left side, they noted that we lose so much evidence, right? We have studies that might have negative results and never get published. Sometimes publications don't actually move into the broader consideration of the evidence base. And then on the right side, they showed that it takes an awful long time to get through these processes if we assume that publication is the way that we make change. And you've all spoken so eloquently so far about all of the barriers, all of the factors that are going to determine whether that evidence actually gets taken up. Now, the punchline from this study was that it takes 17 years to turn 14% of original research to the benefit of patient care. We need to do better, right? We need to move faster, and we need to take more of what we learn and apply it to what we can best do to support patients, families, et cetera. Now, I will note, and James had mentioned this in a side conversation a couple of days ago, that there are cases in which we can do much better and much faster. If we think about, COVID-19, obviously with the vaccines, there was a fair amount of lead-in to, basic science, a whole range of different studies that positioned the vaccines to be created much, much more quickly and then rolled out much more quickly. But it takes that magnitude of a challenge, and still we're not doing justice to the broader world yet. So generally, though, it's taken for 17 years to turn a fraction to benefit patient care. Now, we looked at this, and Gilanetta, who's on the WebEx, was instrumental in developing this piece along with her colleague Shanaz Khan, and I was part of this as well, and just said, in cancer control, are we all that different from that 17-year? Now, lo and behold, when we looked at mammography, we looked at clinicians' advice to quit smoking, colorectal cancer screening, HPV vaccine, HPV co-testing. If you go from the blue to the pink, which is basically mapping what Bayless and Boren did, saying how long does it take to get to an uptake of 50%? It was about 15 years. Now, I'll note that 50% isn't really where we want to go. We want to get to as many people who can benefit from our cancer control interventions as possible. But the point being that as we look in the broader health domain and as we look in cancer, we're not doing well enough to try and move quickly to get our evidence-based practices to be taken up wherever they can. So it does take roughly 15 years in the cancer space. It took 17 years in the broader space. So why does it take so long, and why do we not do so well? Well, the evidence-based intervention for cancer that you mentioned up front that we had in our small groups is only going to be so good as how and whether it's adopted into different systems and communities, right? But not just that, it's whether providers are trained to deliver that practice. But of course, not just that, because we have a lot of training that doesn't necessarily result in practice change. So are those trained providers in a position to be able to deliver those interventions? And of course, not just that, right? We need to make sure that all of those people who are eligible and could benefit from that intervention receive it. Now that 17 or 14%, as I said, had that third number, which was that the likelihood that you would receive the intervention was 50%. You were just as likely to get it or not. Now, if we assume 50% at each of those stages, adoption, the training, the ability to incorporate that into our practice, and then getting it to about half of the people, we're doing okay. But now we're also eliminating all of these other issues that we know are going to get in the way around access, around adherence, around dosage and maintenance. And by going through that 50% sort of declining impact over time, we're down to just about 6% of what we thought we were going to gain with this evidence-based intervention, meaning we need to concentrate on all of these different questions and answer these questions so that we can get these interventions adopted, implemented, and sustained. So this comes from Russ Glasgow. As I said, you're going to hear about a lot of different models going forward, but this is Russ Glasgow and colleagues, their evaluation framework REAIM, which hopefully some folks have heard of, which basically says, how do we get to a broader public health benefit from our interventions? That we've made progress in recognizing the importance of effectiveness of our interventions rather than sort of strict efficacy trials, but we also need to think about reach. We also need to think about adoption. We also need to think about implementation. And importantly, we shouldn't be confident and declare success on day one, that we need to maintain the use of those interventions over time. These are the things that we in implementation science care about. This is what we're trying to optimize. Now, there was some discussion about the what, and I know in the context of universal health coverage, there's this concept of what is it that is included in that coverage. But for interventions in general, we have to think about what is the intervention that we're trying to deliver. Now, I would mention something that I at least refer to as the fish bicycle conundrum, that often our interventions are not necessarily designed in a way that they best meet the needs of our local systems, our communities, and our individuals who presumably should benefit from them. And so it's rather akin, and this comes from an Australian grad student in 1970 who said, a blank needs a blank, like a fish needs a bicycle. You can fill in the blanks. Point being that too often there's that mismatch, that we're creating bicycles for fish who may not be able to use them. Now, it's important that we stick with that really clear definition of what is the intervention. I know Patty had talked about that before, right? So what is the intervention that needs to be implemented? In the context of cancer, sometimes we might just be thinking about that diagnostic test. More recently, we've had a preponderance of genetic or genomic tests. But is that sufficient to say that we're just implementing that? Do we need to include information dissemination? What happens with the evidence or the data that comes from those tests? And is that sufficient? Do we also need to expand to include monitoring and follow-up? Do we include preventive care? Do we include treatment? Do we include all of the above? So anytime we're thinking about studying implementation, we need to start with that what, and we need, in the case of the fish and the bicycle, to really understand whether that intervention can be delivered as intended. Now, you can take the example of HPV vaccination, which experts on this group and in other groups have done a really wonderful job of advancing the idea that we have vaccines that can be preventing of cancers, of various cancers, right? That they are recommended, and there's a particular age range by which, if delivered, the HPV vaccine can do a tremendous job in reducing the likelihood of cervical cancer and other cancers as well. Now, as we shift from the what to the implementation science, we start to think about some of these clear challenges, again, things that many of you have already mentioned so far. So this should probably just be a review, right? We need to be thinking about identifying who's eligible to receive the vaccine. We need to be thinking about how do we promote awareness, understanding, so that there isn't this disconnect between what is offered and what might be demanded or understood, right? Where the vaccine could be given, what's the fit of the vaccine if it's delivered in a practice setting? How well does administration of that vaccine fit within what practices are doing? Can we gather data on reach? How successful are we in broadening the use, the uptake of the vaccine? Are we considering issues around financing? Are we thinking about the workforce that needs to be trained and needs to have the capacity to be able to identify and deliver these vaccines to those who can benefit from it? Now, at this point, I'll just say that for implementation science and affiliated terms, there's often a range of different definitions. And what we like to do, at least for NCI, and for the National Institutes of Health overall, is just present these are the ways in which we're thinking about these terms. So implementation science, which relates to the team that I have the privilege of working with and leading at the NCI, we define as the study of methods broadly to promote the integration of our findings, of our evidence-based interventions into healthcare policy and practice. And just to note that we're pretty broad when we think about policy and practice. It's basically anywhere where we're trying to improve health, where we're trying to deliver care across the cancer continuum. Now, at the NIH level, you'll often hear D&I research, dissemination research and implementation research. And that really came out of a recognition that our research community didn't do either very well, that we didn't do a great job of disseminating our information, our evidence. And we didn't do a very good job of understanding how best to integrate our health interventions into the range of clinical and community settings. So in order to build that knowledge base, we said, these are two things we need to do better. We need a better way of understanding, especially as communication is changing so radically, how best to communicate, how best to spread, how best to disseminate evidence. And that we needed to really think about the complexity that Patty talked about and others have talked about of really trying to embed successfully interventions. So when we think about studying implementation, we're often making a contrast between the typical clinical trial, which really concentrates on the left end and the right end. That what question again? Is it a quality improvement effort? Is it an empirically supported treatment or an evidence-based practice? And then jump to the right. What are the health outcomes that we're trying to achieve? Is it improvement in a reduction in symptoms? Is it improvement in functioning overall? Is it satisfaction? And so our usual trial is going to get at that left and that right. But you'll notice that what we jump over, and this comes from a framework that Enola Proctor and others had developed back in 2009, is this how question. Patty mentioned it earlier. How do we identify those implementation strategies that are going to lead to greater uptake, that are going to yield higher levels of acceptability, of feasibility in delivering those interventions, those implementation outcomes that you see directly responding to the how? Now, the argument that we make is that if we do a good job in not just concentrating on the what, but concentrating on this how, that we should see a knock-on benefit to our various service systems and communities. And you see some of the targets that our Institute of Medicine, now National Academy of Medicine, had laid out as far as standards of high-quality healthcare. And then ultimately, we should see that expansion at a population level to the kinds of health outcomes that we're trying to improve. Now, that how question of those implementation strategies have in recent years, thanks, by the way, to Prajakta, who's on this call for providing this slide, some of our investigators have done a really nice job of categorizing these different types of implementation strategies to the point where we're now seeing much more robust studies of the different types of strategies to support implementation. But you'll see some of them that already relate to the kinds of things that at least I've heard so far today, how we adapt and tailor to context, how we think about developing stakeholder relationships, engaging our consumers, our patients, our families, the financing or the change infrastructure. So these help us to think about what are the targeted ways that we can raise levels of adoption, of implementation, and to sustain over time. Now you're going to hear from Rohit and Eche a whole range of different models, frameworks, theories around implementation studies. We did, that are used in implementation studies. We did 9 years ago a review that had just 61 of these models, and there are resources that enable you to search through them. I'm just very quickly going to mention one, which is Rogers' diffusion of innovations, started with agriculture, but was quickly adapted to healthcare, and says that implementation is based on what does the intervention look like? The characteristics of it. What does the organization or the local community setting look like? And what are the characteristics that help or impede progress in implementation? And then what's the broader environment? All of those issues that nicely have already been mentioned, and that implementation is a process from a decision to adopt to thinking about how we best embed things ideally for the long run and what are the outcomes that we need to track. So if you are wanting to pursue, we would love to see applications, any studies, we would love to see applications coming into the standing program announcements that we at NIH have. You'll see that the National Cancer Institute actually leads these announcements, but with so many different institutes, centers, and offices, and notably, all of these opportunities are available to investigators wherever they're studying and wherever their local institutional home is. So there are no prohibitions on who has access to be able to utilize these kind of funding opportunities. I'll also note at the bottom, and you may have heard about this, but right now we have an RFA on the street that's specifically around implementation science for cancer control in populations living with HIV in low and middle income countries. So hopefully we'll see some of the applications that will really bolster that evidence base coming from you and others. So on our website, we do have examples of some of the funded cancer implementation science grants. Donna Shelley, who's with us today, was kindly willing to share her application around the work that she's done tobacco in Vietnam. You'll see down below Gloria Sorensen's work in India. We see this as a great opportunity to expand the portfolio, certainly including studies across Africa. So please do take a look at these if they're helpful, and please do follow up with us if you have any questions about studies that you want to do in this area. So one other thing that we've tried to develop over recent years, and we were lucky in the US to have a set aside pot of money based on sort of high level government interest in advancing cancer research called the Cancer Moonshot. And one of the main projects that we funded under that was a series of centers in cancer control, some of whom, again, are included as part of this group today with us. I did see Brian Weiner as an example, one of the PIs of one of our 7 centers. But this is building infrastructure and thinking through the connections between our practice settings, our practice communities, and our researchers. And while Moonshot made sure that the dollars were primarily going in the US space, the infrastructure and the expertise that has been built, we feel very strongly is relevant across the globe. And so we just encourage you to think through maybe connecting with one of these centers if you have interests that are common. So where I'm just going to end up is in talking about some of the opportunities, at least that I see might be useful. Hopefully they'll resonate with you. And then we'll get back to our sort of regularly scheduled agenda. So a few things that I think might be resonant, and I certainly heard glimpses of them in our discussion so far. Thinking about sustainment, our interventions are in changing contexts. Thinking about adaptation or evolution of our practices. Thinking about the implementation, not just of one thing, but in the case certainly of universal health coverage or a range of other things, the set of interventions. How do we bundle things across the cancer care continuum? How do we scale up? And importantly, how do we recognize that not all practice should stay, that we might want to de-implement some things? So in terms of the sustainability picture, this comes from a paper that we did now, I guess it's 8 years ago, that said where sustainability is often assumed to be, let's keep everything the same forever. What if we thought much more dynamically about what it means to keep practices delivered and ideally to improve them over time? So this dynamic sustainability framework that we posited, you'll see around the horn, around the sort of circle going clockwise, you'll see that the intervention is changing over time, that the context in which it fits is changing over time. And so rather than assuming we have that what and we don't want to mess with it, and we have that where, and we assume it'll stay the same. What if our goal was really to try and improve the quality of our interventions, find the best place for those interventions within changing contexts, and ideally increase public health benefit along the way? So if you're interested in sustainability, hopefully it's with this idea that our interventions may evolve in the same way that many other things do. Now, in terms of adaptation or evolution of those practices, we recognize that there may be some core ingredients, the key parts of those interventions that are going to make the difference to try and improve patient outcomes. But there's a great need for a lot of different ways in which those interventions could be tailored. It might be around culture, it might be around the mode of delivery or the target audience, it might be around changes in the service setting that are going to require us to think differently about how we deliver our interventions. And so just an encouragement, this comes from a paper that Wynne Norton and I did, an encouragement to think about building out that evidence base on adaptation, because we can learn so much from your experiences and how you're taking some of these existing interventions and modifying them so they work better where you are, and you know best the local circumstances of where you are. So scale up. We need much more thinking, and I think this is a great group to help us there, about how we scale up our interventions. So much of our implementation studies are pretty much looking at the local setting. And while that's important, we don't have the bandwidth to be able to study every single local individual implementation effort. So this is all about how do we learn to deliver things successfully at greater scale. Now, I go back to that what intervention that we're trying to scale up, because often we need to be keeping in mind what is being demanded versus what we are actually supplying. Now, I'm going to go off on a slight tangent and say that in the 1980s, in a particular venue or a particular domain, this was the intervention that folks were trying to scale up. Now, what is this? This is video football. This is the Atari 2600, which was from the 80s, clearly. And this was the state of the art of what video game football or soccer in the US would look like. Now we jump ahead to the 90s and you start to see something that's more recognizable as the sport of football. And so we have to ask the question that once this picture on the right comes along, what is the remaining value of that intervention on the left? Now I'm going to go a little bit further because I have a son who's a football player. And this is what he's playing right now, or this is what he and his friends are expecting to see when they think about this video game football or soccer, right? So again, it's this idea that things are changing over time. And when we focus on what intervention we're trying to scale up, we really need to be thinking not just about the variety of interventions out there, but what's the trajectory of those interventions. Now, similarly, if we're thinking about where, too often from the research end, we're envisioning our academic medical centers as the place in which our interventions are developed. But obviously, you know far better than I that there's a range of different settings where we need to be thinking about scale up, and do our approaches and do our interventions meet people where they are. Similarly, we're often thinking about cities, we're thinking about sort of metropolitan areas on the science side, and we know that there's a broader distribution of people who need the kinds of things that we want to scale up. So again, just things to think to keep in mind if you want to study more on scale up, and we can learn so much from all of you. Now, I mentioned that it's not just about adding more and more, but there's some value in thinking about what might we do less of, because we have a lot of systems that are being asked to do so many things. And so again, Wynne Norton, who I mentioned before, for our team at the NCI has really been leading an agenda around de-implementation, which is nuanced. It's not necessarily about saying we're no longer going to do a particular practice. It might be around restricting use for where it's most valuable. It might be replacing an intervention with something else. It might be that the evidence base has changed in a way that calls us to think differently about our intervention. And so what we'd really love to see is more people who are helping us to understand where you identify practice that isn't beneficial, may actually, in some cases, be harmful. How do we understand the best way to de-implement it? And what are the mix of factors at multiple levels that are going to aid us in that? So just to close off, This is most of what I've said is available on our implementation science website. You'll see 2 members of our team, Prajakta, who was a member of our team and is joined us today, and then Ali Abazid, who's a fellow, just part of the wonderful team that I have the privilege to work with. And just to let you know, if you want to learn more beyond today and beyond the implementation science session tomorrow, we do have a series of resources that we hope you take advantage of. Implementation Science at a Glance was really for cancer control practitioners. TIDIRC is the Training Institute for Dissemination and Implementation Research in Cancer. We have an open access version, meaning that all of the materials are available to be used wherever people can take advantage of them. Take them, use them, however they are beneficial, and let us know what is helpful and how might we change this course over time. We have monthly webinars that really are conversations about where the field is going. And once again, virtually, the 14th annual conference on the science of dissemination, implementation, and health is going to occur in just about a month from now. Guy Lanetta, who has joined us here, is one of the co-chairs of this meeting, and we're really focusing this year on multi-sector approaches to advancing dissemination and implementation science. Final thing is that we've over time developed a consortium that is intended to be a big tent to try and advance cancer implementation science. We've been meeting, like most other meetings, virtually over the last couple of years. And we have action teams that are really focusing on what are the public goods for all of us that are going to help advance the science. You'll see in red that global implementation science is one of the key action groups that we're so excited about advancing the field for us. And so if you haven't joined us for this consortium, we'd love for you to get involved because there are opportunities for us together to think about what we can do. So with that, I just want to say thank you. If you want to continue this dialogue with me beyond today, here's my email address, here's my phone number. If you are on Twitter, that's where I post periodically, and sometimes I have a guitar in my hand. So with that, let me just say thank you. And if there's time for questions, or if we want to go back to the prior part on the agenda, then happy to.
Thank you, Dr. Chambers. We are very grateful for that presentation. Thank you so much. Sure. So if you have questions, please take note of them. We will take them later, or you can keep dropping them in the chat box, and the presenter will keep seeing them there. Okay, so right now we take Dr. Jemima.
Good morning and good afternoon. Dr. Jemima Kamano from Kenya, and I'm presenting on Are we ready? Are we already applying elements of implementation science in projects in Africa? I'm going to give a real life example from Kenya of some work that we are doing in Western Kenya. And my co-presenter is Miriam Schneidman. So we have an organization, Moi University School of Medicine and Moi Teaching and Referral Hospital, together operationalize projects through the academic model, providing access to healthcare. And through this, we have been doing a pilot project that is funded by Access Accelerated through World Bank. And it's a pilot by the Kenya Ministry of Health that seeks to improve access, or to demonstrate the implementation of a model of care that is integrated at the primary level for hypertension, diabetes, breast, and cervical cancer. And it's been running now for 3 years. Next. The main objectives of this program were, one, to explore perceived barriers and facilitators to prevention and management of the selected non-communicable diseases. And I think for today's interest, we are more interested in the breast and cervical cancer level, and in particular, it can facilitate us to knowledge, awareness, early screening, early diagnosis, and then treatment. And using that information to refine the model and describe the process of implementation of this model, and then evaluate the effectiveness of this integrated care model using the RE-AIM framework, which stands for REACH, adaptation, implementation, and maintenance. And lastly, to estimate the costs and the incremental costs of this project as we scale it up. And so in the aim one, where we were exploring the perceived barriers and facilitators for the prevention and early detection of breast and cervical cancer, what we did was a community survey in the 2 counties in Western Kenya, which included 1,800 adults. And the survey had multiple elements. One was assessing the knowledge of the community. Another element was assessing the readiness of another element was to assess the person that we could understand what needed to be done. And secondly, we did facility preparedness assessment in 73 facilities. And through this, we also assessed the healthcare workers' knowledge, availability of equipment and supplies, the health information systems, and the drug availability. And lastly, we did qualitative research using focus group discussions with different groups from the leadership to the community, also to try and understand their perceptions. Next. So from this work, I'll just highlight very few key findings. One was, for example, the healthcare providers' knowledge on breast cancer and cervical cancer was actually very low. If you see the highest graphs show are actually on the low for everything, for risk factors, for signs and symptoms, for modalities of screening, and even for diagnosis. So there was very little knowledge amongst our healthcare workers on breast cancer risk factors, signs and symptoms, screening, and diagnosis. The same applied to cervical cancer. The graphs are pretty similar, so I'll not show the other one next. We also had, before we did the qualitative, we actually looked at availability of equipment. And again, there was a noted scarcity of most equipment. And for the equipment that were available, for example, for cervical cancer, we had cryotherapy equipment in most of the facilities, but they were in boxes. Nobody had ever been trained on how to use them or what their purpose was. And so they were seated there not being used. We also conducted 18 focus group discussions, 9 per county, where we engaged 174 participants, mostly patients, community members, and health workers. And these were moderated by trained moderators and were captured using audio recorders and field notes. And later we translated them. We translated and then transcribed, coded, and categorized them thematically so that they could inform the study. And so you can see there were several of them on breast cancer and also on cervical cancer. Next. So some of the key findings from these interactions in the focus group discussions were we found quite a lot of interesting barriers for the prevention and management of breast cancer. Key was financial challenge that patients said, I have to have transport to even go to the facility so that I can get screened. Even before I have paid, I can't even raise the transport itself. So high levels of poverty, but mostly was ignorance. I didn't know it was important. We've never heard about it. Denial, this can't affect us. It affects certain people. Non-adherence to treatment, lifestyle, and indiscipline, and the fear of hospital procedures, that if I went for breast cancer, in particular, one FGDs, it was recorded that if I went for breast cancer screening, if they find anything abnormal, the doctor tells you that they'll take up your flesh, a bit of your flesh, to go check it. And of course, nobody would want a bit of their flesh to be taken. So there was a lot of fear. And then there was also stigma that if you're diagnosed with this condition, you'll be stigmatized. In terms of the supply side, there was an availability of drugs and availability of the screening services themselves, high cost, shortage of qualified healthcare workers. They didn't, the members of community didn't feel confident in the knowledge of the healthcare workers. They knew that there are no diagnostic equipment. They also feared that there would be poor service provision with improper treatment, late diagnosis, and unfriendly healthcare workers. Next. So these were the barriers that were really quoted for breast cancer, but a lot of them also applied to cervical cancer. But there were also things that they said could help improve. And this was one, if they knew more, then they would accept the condition. If there was a bit of financial stability, or if those these services of screening were covered by the National Health Insurance, if they prayed more, some felt that reducing sexual activity would facilitate reduction of cancer. Some felt that proper breastfeeding Others felt that not breastfeeding would be helpful. Some felt that avoiding male sucking of their breasts would reduce the risk, avoiding pregnancy, if early treatment and so on. And on the supply side, the main thing was the healthcare workers felt that if we understood, would give more health education, would sensitize more, and maybe there'd be more uptake. If there were actually drugs to treat the condition, then people would be more willing to take up screening. If we had the screening tools, then we would screen. If the cost was lowered, if the services were integrated, like for example, for breast cancer, if they were integrated into both the medical patient clinics and into the maternal and child health clinics, and if the service provision was better, and most of them really alluded to if they were remunerated better, they would offer better service. Next. And so from all this information, when we put it together, then we fed it into what we know is a chronic care model. And we were thinking, how do you apply this and improve on the chronic care model and contextualize it using the findings that we have? And this is what we came up with in terms of a chronic care model. So at the level 6 and level 5, but there was very little being done at the primary care level, and that's why all these gaps were found. And so if we strengthened the screening, the education, and the referral process right from the primary care level, we felt this would improve. We had to have an element of monitoring and evaluation, and that told us we had to strengthen the health information system, the data collection, data reporting. And we also felt that there had to be a connection with the community and a connection with the policymakers. Next. So this is what we came up with, and the components of this model were education and screening using 3 different strategies at the community level. So in the community mabarazas, which are meetings that are held for administrative purposes, but often also are used for health education. And these were mostly used to sensitize the community about the cancers. Village screening booths, again led by community health promoters who would camp in each village for a whole week and then would get different groups of people coming in for information, and at the same time would be screened for diabetes and hypertension. Then facility education and screening integrated within the maternal and child health clinics and the family planning clinics, but also open to women who were probably not coming in for MCH services, but were strictly just coming for screening. And in addition, we also set up patients groups, both to strengthen them, to empower them with knowledge economically, and to use them as the advocates within the community. Next. We also had capacity building. As you can see, that was a big gap, both in terms of equipment, supplies, and knowledge of the healthcare workers. And here we strengthened the MOH planning and budgeting and purchasing of the NCD supplies. We rolled out new cancer screening tools across all the facilities, and we did a lot of training of healthcare workers on this. That's a picture of one of the training about how to do cryotherapy. We rolled out new cancer screening tools, including data collection tools, established community revolving pharmacies, which were complementary supply system to the existing supply system for drugs, and would ensure that there was no much stock out. And also we distributed necessary equipment to all the participating facilities, such as speculums, which were very rare before the program, biopsy needles, and so on. And lastly, of course, we conducted a lot of healthcare providers, both didactic training and a lot of mentorship, ongoing mentorship over the next 2 years. Just an example of how we tracked the progress here is breast and cervical cancer knowledge. We did tests before training, we did tests after training, and we've done tests towards the end of the project. You can see the black line shows how low the knowledge level was, and the red shows the improvement in knowledge over time through this program. Next. So in terms of information system, we distributed several Ministry of Health registers, and we worked together with the Ministry of Health to improve the registers that were existing. We printed them, distributed them, and trained key resource persons, in this case, records information officers, on how to do reporting from these tools, and the health workers on how to fill the tools. And because of this, there has been a lot of data reporting to the ministry headquarters going on. And that actually has acted as a motivating factor for the health workers. We held a lot of county data meetings, both audit and also just data meetings to discuss what we found on the audit. And this has kept improving the process. So we were measuring and monitoring the outcomes throughout. And as you can see from the beginning, there was hardly any screening happening when we started in these primary care levels. But by the end of 2.5 years, we had screened 15,141 for cervical cancer, 12,789 people for breast cancer. Interestingly, we have had a problem getting uptake of breast cancer screening. This is more of a health worker issue than we have with cervical cancer. So they're more excited about cervical cancer screening, I think, because there is equipment and all that, than breast cancer, because what we were doing was clinical breast exam, and I guess it wasn't as exciting. Next. Now, when COVID came, the model had to be adapted. It had to be tweaked because initially there were lockdowns. And with time, we realized we couldn't just lose time, and people still needed screening, and some had been screened and needed to come in for cryotherapy, for LEAP, or even needed to go further for treatment. And so what we did is we implemented a strict booking to clinics to avoid crowding. We introduced patient calls by clinics and phone-based triage of who would come in and who wouldn't. We strengthened the support groups and encouraged a lot of self-care and self-monitoring within the groups. We expanded radio-based education because we couldn't hold mabarazas anymore. And we enhanced stocking of drugs and supplies across all the facilities so that patients could get what they needed much closer home than we had even envisioned initially. And this is a picture of a few of our support group meetings, all of them with the beautiful blue masks, which we distributed to them. Next. So the key message from this model is, one, we really have come to appreciate the role of context and lived experiences of patients and other key stakeholders in facilitating development and rollout of realistic interventions. So no matter how good an intervention is, we really must understand the context, because there's a lot that had to be tweaked from the original chronic care model for it to work for these communities. We also realized that well-trained healthcare workers, engaged patients, and mobilized county authorities contribute a lot to quality of care and sustainability. And we have really engaged the county leadership over time so that we can put in more and more sustainability measures. Practicable strategies are required to facilitate community-level prevention, early detection, and treatment of these diseases. And flexibility in implementation and innovative strategies along the way we must be open to adapting this, because there are always shocks that we'll find as we move on. And now I hand over to my colleague, Miriam Schneidman, for the remaining part.
Thank you so much, Jemima. So colleagues, I just wanted to share with you some reflections on what this pilot has to do with the science of implementation. When we started the pilot, we never spoke about the science of implementation, but now that I've listened to the various colleagues have spoken before us, this pilot is all about the science of implementation. So what was the problem that we're trying to address here? And I think from all the previous speakers, what we heard very, very clearly is what we see in Africa is lack of awareness, late health-seeking behavior, and then lack of access to services in general, particularly in terms of early screening, detection, and rapid diagnosis and referral. So this pilot was all about looking at an integrated model of care that would facilitate access to screening and to treatment for 4 tracer conditions. And we really wanted to learn from all of this. The other key point I wanted to make is that this Kenya pilot was one out of several pilots that the World Bank was supporting with financing from Access Accelerator. We had a similar project in El Salvador that dealt primarily with cervical cancer. So from the inception, there was always a heavy emphasis on learning, knowledge sharing, and documenting good practices, and learning what works, what doesn't work, and how much it costs. if you look at the diagram on the right side, there are a number of elements in this process. Obviously, initially, we wanted to conduct some assessments to understand better the health system barriers. Secondly, we realized it would be critical to establish the capacity of the participating sites in these 2 counties in Kenya. Thirdly, deliver the care. Fourth, monitor, track, and evaluate the performance. And most importantly, share the lessons and the experiences with other counties in Kenya, which could eventually replicate some of the innovative interventions. So if we look now at the science of implementation and what this model taught us, I see really 6 main elements that were used in terms of the science of implementation. The first one, I think Dr. Kamana already referred to this, and many other speakers did as well, the importance of understanding the context. So you've heard from Dr. Kamano how there was a heavy emphasis on understanding the barriers and the facilitators to prevention and management of NCDs. There was extensive consultation with the 2 local county authorities to understand the role, to help them to understand better the importance of these interventions. And there was ongoing consultation with the Ministry of Health in Nairobi, because we didn't want this to be an isolated pilot. We wanted them to really own this pilot, to learn from it, and to help to support this nationally. Second, as we have heard already, there are a number of strategies that were identified, a number of gaps and a number of strategies. Obviously, capacity building was critical, training more people to provide these services, both healthcare workers and volunteers, dealing with the supply chain. There was an innovative use of revolving drug pharmacies, community education. You know, there are many, many aspects of the health system that were addressed. And one of the most innovative ones, in my view, as we had a discussion of UHC earlier, there was a strong emphasis in helping the participants in the program to enroll in the National Health Insurance Fund, right? So there were income generating activities so that they would be able to pay the premium into the NHIF. So there were not only innovations in terms of delivering services, but looking at the demand side. You know, it's not enough to design the program. You have to make sure that people can access those services and that they have financial protection to be able to do so. Thirdly, there were a number of key indicators that were monitored over time. One was, did community awareness improve? You know, the levels of knowledge and awareness at the inception of this project were very, very low. The National STEP survey in Kenya also showed very low levels of knowledge. And these 2 particular counties had exceptionally low levels of awareness. Secondly, was there improved access to screening? You know, where more people screened over time. And then thirdly, did that lead to management of these selected NCDs? So for example, for hypertension, did people reach better levels of management of their hypertension? The other 3 points I wanted to raise, which I think really also are very much in line with the science of implementation, is the adaptation to changing context. Dr. Kamano, you know, obviously she spoke about the COVID-19 pandemic and how they adapted the model to that. There were other shocks, there were floods, you know, there was staff turnover, there were problems with having, you know, workers striking. So the importance of constantly adapting the model of care and looking at sort of new ways of doing business. You know, in my view, if we look at things like provision of drugs for longer duration, or using more telemedicine options and strategies, that is really going to help us at the end of the day, once this pandemic is over, to deliver services more efficiently. And that's very, very important because the level of resources that the ministries of health and governments are capable of allocating is not excellent. It's not really very good. So efficiency is going to be really critical. The next point is collaboration and partnerships. I think Dr. Kamano would be better placed to speak about this, but really, this was a really multidisciplinary effort, including researchers in Muay teaching and referral hospital practitioners, the donors. I was also involved in this. So there were really many, many people that were involved. The private sector financing this pilot project. So partnerships are really absolutely essential to anything and everything that we're doing. And then maybe the final point I wanted to make is the whole challenge of scale up and sustainability. Once we attain good results in our small pilots, we need to scale them up, right? So there were a number of elements that were used and a number of strategies to kind of promote the scale up and the sustainability. One of the key ones was really to initiate a policy dialogue with the 2 county authorities that were involved in this process. We wanted them to understand the importance of early screening, the importance of allocating more resources, the importance of plowing back the revenues from the health facilities into the health sector rather than into the general local government budget. Obviously, the collaboration with the Ministry of Health was critical as well because they designed the national health plans, and we want them to ensure the uptake of some of the innovations from this. The second aspect, which is really absolutely critical, and the work is still underway, is to estimate the cost of doing all this and the budget impact. If we want to scale up innovations, we need to know how much they cost and how that could be funded, right? So if you want to share the information with other county officials, you need to really give them a good sense of what is the cost of doing this and what are the expected benefits as well. And then finally, the whole learning and knowledge sharing. So the whole idea was always to facilitate learning and knowledge sharing within Kenya with other county officials, and also facilitate learning and knowledge sharing globally at the bank. The World Bank kind of prides itself of being a knowledge institution. So a lot of the projects that we fund, we expect them to have catalytic value in terms of learning, generating knowledge and experience, and sharing it with other countries. So just in conclusion, there were partnerships were absolutely critical to everything that was accomplished. This is still work underway. The project was implemented in the middle of the pandemic. So some of a lot of lessons, a lot of achievements, and a lot of challenges, ongoing challenges as well. So I just wanted to acknowledge the many people that collaborated in this, both the investigators and some of the implementers. Thank you so much, and we look forward to any questions you may have. Thank you.
Thank you very much, Miriam and Dr. Jemima, for that wonderful presentation. We're very grateful to have you on. So if you have questions, please can you drop them in the chat box? The presenters will be able to pick up your questions in the chat box. So we'll quickly go on to the next presentation, and that will be taken by Dr. Ramaswamy and Dr. Echezona. So we will be looking at theories, frameworks, and models and implementation science.
Okay, good afternoon, everybody. And thank you so much for this opportunity to present today. What I'm going to talk about, you will find, actually, this has been an ongoing theme across the presentations today. So you will see in what I am presenting some commonalities with what Dr. Chambers presented and what the previous presenters talked about. And so I think as you're listening to all of these different presentations today, you will begin to hear the same themes, the same language, the same frameworks, the same ideas being presented by a variety of those who are talking today. And hopefully that allows you to be able to kind of consolidate overall kind of the key ideas in this field of implementation science. So I'm going to talk about common frameworks in implementation science. As Dr. Chambers said, these things are called models, theories, and frameworks in the field. So you will hear them referred to as models, theories, and frameworks. These are often used, these words are used interchangeably in the field right now. I think there are some differences between models and theories and frameworks, but I'm not going to go into that today. What I'm going to primarily talk about, I'm going to use the word frameworks. And I'm going to present, as Dr. Chambers said, there are over 160 frameworks that are currently being used in implementation science. And obviously in my 30-minute presentation, I am not going to be able to do justice to all of them. I'm going to talk about 5 frameworks that have been used most often by implementation researchers and practitioners, those that have made their way into low resource settings. And I'm going to talk about them in a little bit of detail, more to kind of give you a sense of what is the different ways in which we can use framework in this field. How have they been used in low resource settings? What is it that we know and what is it that we don't know about the use of frameworks? And what are some of the research ideas and research questions that still need to be answered, that need to be led by researchers in Africa, by researchers in low-income settings, so that we can begin to advance this field. So, implementation framework. An implementation framework is a framework which is a proposed model of factors likely to impact implementation and sustainment of evidence-based practice. And when I say a proposed model, obviously it's not the reason that there are 160 frameworks in this field is that there is no one magic solution that says this is how we want to be conceptualizing all of the factors that affect implementation. Different researchers and different practitioners, based upon their needs, based upon their particular context, have developed different ways of looking at how to categorize and assemble and synthesize factors that affect implementation. And so this is what has led to these 160 frameworks. So the reason that there are so many frameworks, part of this represents the diversity of the field. It represents the fact, as Dr. Chambers said, the fact that there are multiple contexts and then different contexts, the way of thinking about these frameworks needs to differ. But of course, it has also led to a tremendous amount of heterogeneity. And so part of our thinking as I'm talking today, part of this is to begin to think about, what are some common ideas behind some of these frameworks? What is it that we want to use them for? And what is it that we want to do with them? And those are some of the kinds of things that I'm going to talk about today. In general, the other thing to be thinking about as we think about frameworks is that the field of implementation is complex. And as Dr. Chambers said, when he talked about the dynamic sustainability framework, things evolve over time. And not only do things evolve over time, as the previous speaker said, we want to be thinking about different levels at which implementation takes place. So there are policy levels, there are clinic levels, there are patient levels, there are provider levels. And so what we really want to be able to think about when we think about implementation is at what stage are we during the implementation process, and at what level are we considering the factors that affect implementation. And so what these frameworks do is these frameworks serve to be a way of being able to, in a relatively simple way, in a relatively systematic way, assemble the enormous complexity that exists in this field and be able to kind of create a set of categories against which we are able to understand where should our area of focus be. What are all of the different factors that affect our quality of implementation? And how do we begin to think about where we are at a particular point in time or where we are at a particular level in our implementation that allows us to be able to focus on where the factors that affect implementation are, and how do we begin to think about strategies to address these factors? So let me start a little bit with talking about how frameworks are used. So as I said, there are multiple frameworks have multiple utility. The previous speakers talked about using REAIM for evaluating their program. I will talk about REAIM today as well. But overall, there are 4 different ways in which we can think about using frameworks in implementation science. The first is to think about the goals of implementation. What is it that we want to achieve as a result of implementation? And Dr. Chambers talked about these outcomes, and I'll talk about that in a minute. So one of the uses of frameworks is to think about the outcomes of implementation. The other use of framework is to understand factors that affect the quality of implementation. And in the literature, these are called determinant frameworks. So this paper by Nielsen that is cited here is the seminal paper that takes that this is now already 7 or 8 years old, that takes all of the different frameworks and categorizes them into these different buckets. So a determinant framework is a framework that is used for understanding and explaining factors affecting the quality of implementation. Then there are certain frameworks that can be used as a guide for practitioners, as a step-by-step process to think about implementation. How am I going to actually implement? What are the different things that I need to be paying attention to as I'm implementing? And those are called process models. And these provide a roadmap to support the implementation process. And finally, there are frameworks for evaluating implementation, and these are called evaluation frameworks. As I am presenting this slide, I want to make sure that these things these are not cast in stone. It is not as though I cannot use an evaluation framework for planning, right? So I want you to kind of pay attention to these, not so much to think about these are rigid buckets and we can't move a framework from one bucket to the other, but generally to think about this is the way these frameworks have been used. As I talk about the 5 frameworks that I'm going to present today, I'm going to talk about 1 or 2 in each of these categories, so you begin to get a sense of how these are used. But I want to reiterate once again that as practitioners and as researchers, one of the things to think about is, what is it that you want to do? What is the implementation research problem that you're focusing on? What is the implementation practice component that is important for you? And what framework is going to fit? So rather than thinking up front and saying, oh, this is a determinant framework and therefore it's not a good match for me, it is, I think my suggestion is you want to be able to start with what your goal is, and then think about what framework is most appropriate for you. So having said that, I'm going to cover 5 frameworks in some level of detail today, and then I'm going to give you a list of a few other frameworks that might be useful to you. And the 5 frameworks that I'm going to talk about are the outcomes framework that I talked about, that comes from Dr. Proctor, that presents the idea of implementation outcomes. I'm going to talk about 2 determinant frameworks that have been commonly used. One of which is perhaps one of the most popular framework that exists today, which is called the Consolidated Framework for Implementation Research, or CFIR. I'm going to talk about another determinant framework called EPIS. And then I'm going to talk about REAIM, which was mentioned by the previous speakers, which is an evaluation framework. And then I'm going to talk about a process model, which is slightly different. It has a different lens on implementation, and that's called the interactive systems framework. And what I'm going to talk about is the basic characteristics associated with each of these frameworks, and then give you a sense of to what extent do we know about the applicability of some of these frameworks in low resource settings. And as I said, what are the other research questions that still remain that need to be answered? Okay, so let us start with the outcomes framework. As Dr. Chambers mentioned, implementation outcomes. So what the outcomes framework that Dr. Proctor developed deals with this idea of implementation outcomes. And the implementation outcomes are the preconditions for attaining, are the things, the preconditions that need to be in place in order for me to be able to achieve health or service outcomes. So the idea is that from what I have as my intervention, which is on the left-hand side of this chart, to what I have desired, which is a health outcome, which is the right-hand side of this chart, in order to go from intervention to outcomes, I need to be able to implement, and I need to be able to implement well. And the implementation outcomes, and this is the focus of implementation research, as Dr. Chambers mentioned, is to be able to understand what are the goals of my implementation process? What are the things that need to be in place in order for me to achieve my health outcomes? And so Dr. Proctor came up with these 8 implementation outcomes: acceptability, adoption, appropriateness, costs, feasibility, fidelity, penetration, and sustainability. And the idea is that it's not necessary that each one of these has to apply for every particular research problem that I have or every particular practice setting that I have. But the idea is that by being able to think about implementation outcomes as my pathway towards achieving my health outcomes, it helps me to better understand the kinds of things I need to be paying attention to. So for example, if there is an intervention, we do a lot of work in Ghana right now. And one of the, in maternal child health, and part of the questions that we're asking as we're beginning to implement a set of neonatal interventions in tertiary hospitals in Ghana is to what extent what we're trying to do is we're trying to change the systems of delivery that provides midwives and frontline staff with greater autonomy, with greater decision-making power, so that they can be taking the decisions that are needed to save the lives of mothers and babies without necessarily needing to wait for a specialist. And so while this is some of these interventions, some of the training packages come from models that have been tested, but in order for them to work, in order for us to be able to implement them, they have to be acceptable to the specialists. Without acceptability, we are not going to be able to achieve the health outcomes. Likewise, in order for this to happen, we have to make sure that the midwives have the time and the capability while they are taking care of mothers to be able to do the right diagnostics and to be able to take the right decisions. That's a feasibility issue. So how implementation outcomes help us in this process is by being able to say, what are the kinds of things we need to make sure are in place before we can have a decent degree of confidence that this particular intervention is going to result in the outcomes that we desire. And so using this implementation outcomes framework as a starting point for thinking about what I need to be focusing on helps me to think and structure and plan the implementation process better. Okay, so let's move on to the Consolidated Framework for Implementation Research, CFIR. And as I mentioned, this is a determinant framework. And what a determinant framework is, it allows me to develop categories of the kinds of things that affect the quality of implementation. And so, as I mentioned earlier, there are these factors that affect the quality of implementation can take place at multiple levels. And so CFIR talks about the different factors that affect implementation could be associated with the intervention itself, right? So my intervention could be complex. My intervention could be perceived as not being of value to the organization. So there could be something about the intervention itself that affects its ability to be implemented. The individuals involved in the intervention, their beliefs, their ability to feel that they can actually implement the intervention, their perceptions about the value of the interventions. These are some of the kinds of things that affect the quality affect our ability to implement. Likewise, the process itself, if I have a particularly complicated process for implementation, if it is requiring resources that don't exist, if it is requiring multiple steps that are over and above what is actually done in the organization itself, then the process might serve as a barrier to implementation. The inner setting, so the culture of the organization. For example, if the organization is especially rigid or hierarchical, or if it turns out that the organization is not, but change doesn't come to the organization easily, but organizations are unwilling or unable to accept innovation, then those could be situations where I have barriers to implementation. And finally, the outer setting. This has to do with the policies. It has to do with the government systems. This has to do with the environment. So there might be political or policy-related issues, resource-related issues that have to do with the National Ministry of Health that affect my ability to implement. And so what CFIR does is it takes these different levels and places them into what we call these different domains. So the implementation is affected by the intervention, the inner setting, which is the organization, the outer setting, which is the environment, the individuals involved, these are the people who are actually delivering the intervention, and the implementation process. And what this framework allows me to do, underlying each of these different domains, these different buckets, are particular elements that affect these buckets. So for example, if I'm thinking about the characteristics of the intervention source Is it a credible intervention? Is it something that has been used elsewhere? Is it something that I can trust? Is it something that comes from a body of evidence? Is it something that others in my peer group are using, and therefore I have confidence that it is something that I can use? So for each of these different buckets, CIFAR allows me to come up with, has a set of kind of individual elements that are related to these different categories, these different domains. And in this, the CIFAR is well supported with website and other resources that allow you to be able to talk about how do we define each of these, and how do I adapt them to my particular context? What might be measures that allow me to be able to measure the extent to which these different factors affect the quality of my implementation? So the advantage of a framework like CIFAR is it is so broad that it is unique. It is widely applicable to a variety of different contexts, which makes it very flexible and which makes it very versatile. But of course, the risk is that because it is so flexible and versatile, it needs to be adapted to the local context. But without doing some intentional adaptation, it might turn out that it feels confusing to use. It feels overwhelming. And a lot of practice-based applications, a lot of people who are trying to apply this in practice often find it difficult to use. So here is a study that was recently done that looked at the application of CIFAR to low-income settings. And what you see here on this graph are across these different elements of the domains, the researchers try to get a sense of which of these elements are compatible with low-income settings, and which of these are incompatible, and which of these are irrelevant. And as you can see, some of the things related to culture, for example, is completely compatible. All of and so this comes from a bunch of survey participants who were asked to rate each of these different elements in terms of their compatibility, incompatibility, and relevance. And so certain things, obviously things like adaptability, whether the intervention is adaptable or not, is something that is relevant, is a relevant factor that affects implementation, irrespective of whether it's in a low-income setting or any other setting. Similarly, something like culture or something like knowledge and beliefs, these are transferable across contexts, these are transferable across countries. Some other things, such as patient needs and resources, the interviewees felt that only a portion of the interviewees felt that this was compatible with low-income settings, and that more than half of them felt that they were incompatible or irrelevant. This particular study has a very small sample size. There are only 19 interviewees, and the study was done by researchers from higher income settings from the University of Washington. So, but this is the kind of study that is really useful as we begin to think about the use of these frameworks in a wide variety of settings. Being able to have these kinds of studies that are initiated by and led by researchers from low-income countries who can interrogate and explore these frameworks in a way that allows them to truly understand what works and what doesn't work. How do these need to be changed? To what extent are some of these constructs appropriate and not appropriate? Do we need to change the language of some of these so that they make more sense to the context? So there's a lot of work that is still useful, that needs to be done, but some of this work has already begun in transferring some of these frameworks to low-income settings. Okay, I'm going to move on to talk about another determinant framework, and this is the EPIS framework. EPIS stands for Exploration, Preparation, Implementation, and Sustainment. And if you look at the way in which this framework is different from CIFAR, is that it also is a multi-level framework. So as you can see here, there are outer context and inner context settings that are similar to the inner and outer setting domains in CIFAR. And so it talks about what are the factors that have to do with sociopolitics, with funding, with internet use. These are things that are outside the individual organizational context, and perhaps are regional or national things that need to be paid attention to. But at the same time, there are also inner contexts, the organizational characteristics, the adopter characteristics. So the EPIS framework also is a multi-level framework that looks at different the effect of context on implementation. But what it also does is it introduces a temporal dimension, a time dimension into the implementation process. So it recognizes that implementation is not something that happens instantaneously, but is a staged process. That there are different stages across your implementation continuum, and that initially, so there might be what you might need to do is you might need to explore the context. You might need to get a better understanding of is this context right for implementation. Then the next thing that needs to happen is you need to be able to prepare the context for implementation, which means this might be garnering resources, getting leadership support, hiring staff, training staff, building the support. And then the implementation takes place. And then, of course, finally, we need to kind of make sure that whatever we have implemented is sustained over time. And across each of these different stages, there are multiple levels of factors that affect our ability to implement. There are barriers to implementation. So the FS framework is an extension or a different way of looking at the barriers to implementation that involve both the different levels as well as stages over time. Okay. I'm going to talk briefly now about an evaluation framework. This is the framework that was mentioned by the previous speakers. This is called RE-AIM, and this has been a framework that's been around for a very long time, for more than 20 years. And RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance, as is evident. And the idea, of course, is that, as Dr. Chambers says, it's not, as we begin to think about what is it that we really want to know about implementation, it's not enough simply to ask, did the intervention work or did it not work? Yes, I mean, that is obviously an important question. It's important to understand whether the intervention produced an effect. But it is equally important to know under what circumstances did it work? For whom did it work? What are the factors that prevented it from working? And so the RE-AIM framework allows us to go beyond simply effectiveness, which is whether the intervention was effective or not, and begin to understand other dimensions and other considerations that are important to assure the effectiveness of the intervention. So, for example, I might need to ask, how do I reach those who need this intervention? If I don't reach them, or I only reach a subset of the population, or I only reach the urban population, or I miss those who are the most vulnerable, then I might have an effective intervention, but it doesn't advance public health goals. How do I incorporate the intervention so it's delivered over the long term? Once again, in terms of sustainment, I might have an intervention that is effective as long as the program staff are involved in it. But once the program staff go away and once the resources go away, if it's not embedded within the Ministry of Health, for example, then it is not sustained over the long term. So I need to think about sustainment. I need to think about implementation. How do I make sure that the intervention is delivered properly? And finally, how do I develop the organizational support to develop intervention? How do I make sure that it is appropriate? How do I make sure it's acceptable? So all of these factors are important. And so RE-AIM serves as a good conceptual model to pay attention to all of these different components of the implementation process. As always, the challenge is in different contexts. The question is, how do I measure these? And what does it conceptually mean across different settings? And so there was a recent study that was conducted, actually, Dr. Gila Neta, who's here listening today, was one of the authors. And this shows the application of the RE-AIM framework to a different applications. An environmental application is clean fuel cooking programs. And what this picture shows is results of a survey where respondents were asked. And so what the interviewees were asked was the level of conceptual challenge across each of the RE-AIM dimensions. So, for example, how difficult is it for you to conceptualize what reach means? How difficult is it for you to conceptualize what maintenance means? And then the second question that they were asked is the level of difficulty gathering data. How easy is it to be able to measure reach? How easy is it to be able to measure maintenance, for example? And what you're seeing here, the color coding talks, the purple are the ones that are the easiest, and the reds are the ones that are most challenging. So you see, for example, in terms of level of conceptual challenge, reach is fairly well understood and fairly well measured. People understand what it is. People have different ways of measuring it. But something like maintenance, first of all, it is hard to understand what maintenance means because sustainment or sustainability could be different things in different contexts. So to begin to get a sense of how do I take maintenance and how do I make it work for me? What does it actually mean for me? How do I adapt the knowledge or the meaning of maintenance for my context? These are kind of questions that are context specific. And so we need to be able to think about research that allows us to be able to say, how has maintenance been defined across multiple settings? How has maintenance been defined in low income settings? How do we begin to use this knowledge about the applicability and application of REAIM in multiple settings so that we begin to build a universal body of knowledge about what are the kinds of things that are common across these frameworks and what are the kinds of things that are different. Okay, the last framework that I'm going to cover in some detail is what is called the Interactive Systems Framework. This was developed by Dr. Wandersman and others, and it offers, it's a process model. It's a model that allows practitioners and researchers to think about how to approach the process of implementation. And what this framework says is that there are 3 different systems that need to work together in order for implementation to be successful. There has to be, these 3 systems are called the synthesis and translation system, the support system, and the delivery system. And the idea is that that in order for me to be able to implement an evidence-based intervention, first of all, it needs to be translated. So it has to be adapted to the local context. If I'm not translating it, then if it doesn't fit, if it's not appropriate for the local context, then it is not going to get implemented well. So I need to have a system that looks at, synthesizes the evidence that exists and translates it in a way that is appropriate and applicable for the context. Then I need to have a support system. Merely the fact that I have a adaptive intervention is not going to magically mean that it's going to get implemented. There is going to be the need for supporting the implementation process, which means that there needs to be an explicit and intentional capacity building component. We have to be able to build the capacity of those who are implementing, not only around the innovation itself. So that's innovation specific capacity. It refers to the fact that the people who are implementing need to know what they need to do. But I also have to build general organizational capacity. I have to build leadership. I have to be able to build the adequate resources. I have to be able to look at organizational culture. So there needs to be an explicit support system that allows for the implementation to be effectively instantiated within the organization. And then finally, of course, there's the delivery system. So the people who are actually doing the implementation are the frontline staff. The people who are doing the implementation are the ones who are working, either they're service providers or they might be midwives, but they're the people who are working day-to-day in these environments. And so being able to think about how can I provide the support so that they can take the knowledge that has been developed and how can they actually put it to use in their everyday work is another important consideration. And so these are the 3 systems that the Interactive System Frameworks talk about. And we have used the Interactive Systems Framework quite in a variety of different settings. Some of our work in Ghana use this. And part of how this framework has been useful to us as it has allowed us to be able to explain to our stakeholders all of the different components that need to be in place in order for us to implement well. So it's not a determinant framework in the sense that it identifies the factors that affect implementation, but it has allowed us to be able to structure and implement a context-appropriate implementation process in a way that suits the context, that allows us to be able to identify the kinds of things that need to be in place and to make sure that all of the different systems are fitting together well. Okay, I'm going to wrap up my talk in just with the talking about a bunch of other frameworks that might be useful. And these have to do with other components of implementation. So the first of those is one that Dr. Chambers already talked about, the dynamic sustainability framework. So this is a framework that can be used for exploring what are the kinds of things that need to happen in order for me to sustain an intervention. There are a large variety of scale-up frameworks. One of these is from the Institute for Healthcare Improvement as a framework for going up to full scale. Equity is becoming really important as a factor associated with implementation, making sure that our implementation is equitable, that it is addressing the needs of the most vulnerable population. So there are a variety of equity frameworks that have been developed as well. We talked a little bit about outer settings, about policy strategies. While a lot of implementation related work is organizationally focused, ultimately, if large scale structural changes and transformation needs to happen, we have to be able to look at policy issues. We have to be able to look at issues beyond the organizations itself. And there are a variety of frameworks that allow us to be able to understand how to integrate policy related factors into the implementation process. And finally, there are other there are a variety of other implementation roadmaps that might be useful. One that is again commonly used, especially in US-based settings, is one called the Getting to Outcomes framework. That provides a step-by-step approach to the implementation process. Once again, the idea is that there are a large number of frameworks that are available, and paying attention to the ones that are that fit your particular context the best, being able to explore them a little bit to understand whether these will work for you or not, and spending a little bit of time looking through these frameworks will help you to be able to think a little bit more carefully about what might be the right framework for your particular research or practice-based application. I think Dr. Chambers mentioned 61 frameworks in 2012. This is a review in 2018 that have now identified 159 frameworks used for implementation. And so certainly you have an enormous number to choose from. What I find often in the work that I do is because there are a few of them are particularly popular, and those are some of the ones that I showed you earlier, there is a tendency for people to just jump to these frameworks because they are the ones that are seen most often. My advice is it is well worth looking at some of these other frameworks. It might turn out, for example, that some of these other frameworks are more suitable for your particular use, especially if you're trying to talk about communication. If part of the goal is to be able to work with different stakeholders to help them understand how to think about implementation, you might find that one of these other frameworks is more useful than something like CFRS. And so I think the time to think a little bit about which framework makes sense and to try some of them out and to get a better understanding of the extent to which these are appropriate or not appropriate for a setting, I think that this is something that I very much encourage you to do. There is a tool that has been recently developed called the TCAS tool that allows both researchers and practitioners to compare frameworks. These are the different categories across which these frameworks can be compared. So usability, testability, applicability, and acceptability. Once again, being able to use some of these tools to think carefully about and in a systematic way about what the differences across these frameworks, the ones that are, what the similarities and differences are, how they are applicable or not applicable to your context. So doing this kind of work, I think, is both, I think, to move the field forward from the perspective of being able to understand, how to advance the science of frameworks across low-income settings, but also in a practical way to be able to help you to make better informed decisions about which framework to use. So kind of thinking about the choice of frameworks systematically makes a lot of sense. Finally, this is the last slide that I'm going to show. We often have, because there are so many frameworks and because they are so overwhelming and because the frameworks have adopted a central place in implementation science and implementation research, we often tend to think about implementation about the frameworks as just the end in themselves rather than as a means to an end. And what I want to point out is that the role of these frameworks is to help you to do better implementation practice or to do better implementation research. But ultimately, the frameworks are only the means to the end. They're only things that guide you along the pathway of creating your implementation approach. Ultimately, what we need is to get to implementation strategies, which is what our next speaker is going to talk about. And I think Dr. Chambers touched on briefly. The implementation strategies are the kinds of things, the approaches, the actions that we need to take in order to improve the quality of implementation. From a research perspective, there's a real need to know which kinds of implementation strategies work in which settings. From a practice perspective, there's a real need to be able to apply implementation strategies in a systematic way so that we can improve the quality of implementation. The frameworks allow us to be able to identify the factors we need to be paying attention to so that we can design the appropriate implementation strategies. And so, not to throw another framework into the mix, but the work that we have been doing, we have been talking about it within the context of what we call the model for implementation. And the model for implementation basically says, if your goal ultimately is to be able to think about testing, adapting, and developing strategies that support your implementation. In order for me to be able to do that, I need to understand the implementation outcomes that are critical for me. I need to be able to use the frameworks to understand the factors, the barriers, the determinants that affect the achievement of these goals. And then I need to be able to use use my understanding of these determinants to be able to develop and test and adapt. And the plan, do, study, act cycle, which you saw on one of Dr. Chambers' slides as well, is a iterative way of being able to, for me to be testing strategies on the ground. So I need to be thinking about what implementation strategies are most appropriate and how do I use these kind of methods to be able to test and adapt them on the ground. And that is really the goal of what we're doing. And so the extent to which I can use these frameworks to help me to come up with strategies, that's the ultimate goal. And so using these as the means to the end in a systematic way will help you to be kind of better implementation practitioners and better implementation researchers. Thank you very much, and I'm going to hand over now to the next speaker.
Thank you, Professor Ramaswamy. We are very grateful for your presentation. We are really very far behind schedule. We still have a presentation more to take.
So thank you so much. And as you could probably hear already, one of the challenges when I looked at the schedule is that I'm going to be speaking after Professor Rohit, who is talking about frameworks. And I remember the first time I was sitting down in a conference and someone was trying to explain these frameworks to me. And I know they needed more than 30 minutes. And then the second thing when I look at the schedule is that I'm going to be the speaker who is standing between you and your 10 minutes break. So I'm not in a very enviable position to speak. So what I decided to do with my speech is really to divide them into three. I have 30 minutes for this speech. I'm going to try to cut them down because we're running late. I'm going to divide them into three. I'm going to spend the first 10 minutes telling you my implementation story. I'm going to spend the next 10 minutes trying to prove to you that you already know how to choose implementation framework. And then the last 10 minutes, I'm going to kind of give you some idea of how you can make that knowledge even better. So what I'm going to do, next slide, what I'm going to do I turn my slide or does it move automatically? So in the first part of the story that I want to tell you a little bit about my story, my implementation story is that I took my child to the kindergarten and then the principal wanted to have a meeting with me. And he asked me and said, every parent that bring their child to the private school, we want to see what is it that the parent want out of the school for their child. And when they asked me that question, I looked at them, I said, all I really want you to do for my son is to make my son like school. So what I'm hoping that in the 10 minutes that I have initially telling you this story is that at the end of the day, that you're going to see what role it can play in your career, what role it can play in your practice. And then I want to make you like implementation science. So having said that, you'll find out that in the implementation science, you're going to have people from different specialties, different training. But that's the beauty about implementation science, because these ideas are not shared around. And you remember this quote is that you can share those ideas, don't reinvent the wheel. That the evidence, if it is there, use them, share them, don't redo things that are done. And my belief in implementation science is that if we can implement what we currently have evidence for, we could impact 80% of the problem we seek to solve. So the only thing that is requiring new ideas and new evidence is the 20%. So that's one of the beauty things about implementation science. So along my way, what I noticed when I joined my faculty, the fact that I believe that if we can implement what we already have evidence for, that we can impact 80% of the problem that we seek to solve. That the only 20% are the ones that require new ideas and new evidence. And along the way, for everybody who have done this, you find out there are stories you have and how you finally came to the aha moment that what you have been doing was implementation science. And that's what happened to me. When I joined the faculty as a pediatrician and a pediatric infectious disease doctor, I was attracted to asking several questions. I was seeing HIV-infected women and trying to prevent transmission of HIV from mother to child. So one of the things I noticed was we have this regular annual pap smear for women who are infected with HIV, trying to identify cervical cancer. It has been shown that if you can identify it early, that it can cure it. But what happened that only 50% of our patients we are doing pap smear, even though it was available, it was free, and they can just schedule for it and do it. But only 50% of them were doing so. But I find that that problem is now limited to that area. We also know that we can prevent mother-to-child HIV transmission, but we know that we have the evidence to do it. But we know that at that time, for example, in Nigeria, we had 75,000 children that are born every year with HIV, even though that evidence exists. So I found that I was attracted to this. So for the next 5 years of my career, what I noticed was that I get gravitating to answering these questions. And by the time I was 5 years into my career, I had 25 grants, I had 100 publications, I had 1,500 abstract and 15 publications. So I said, you know what, I need to take a break. Something is not working. What I found out is that I was a clinician, 100% clinician. There was no protected time for research, but I was attracted to these questions. And what I did do was to look at 1 year grants, and try to put into answer the question that I have, how can I improve screening for pap smear among my patients who are HIV infected? So one of these things, after the 5 year, I took a break and I went to DC as a Robert Johnson Health Policy Fellow and spent a year with Kathleen Sebelius when she was the Secretary for Health in the United States. So two things that happened along the way, and that's why I put these two names here, that changed things. I wanted to meet with Lauren Starbuck, who was at the time, and I think is still the principal deputy at NIH, because I wanted to ask him that I have done all these things. Why is things not working for me? I have written 10 NIH grants to help me build a career research, but it wasn't working for me. So he did one thing for me that I think everybody should have a chance to. He asked me to meet an NIH program officer, which I did. But the good thing is that when I was supposed to meet with NIH program officer, 5 of them came. And they asked me to send my CV to them. And they looked at my CV. So when I sat down with them, they said, you know, one of your problems, you are so scattered. You are doing things in HIV, you are doing things in cancer, you are doing things in contraception. So you are so scattered, you need to focus. Then one of the program officers said, you know what I see from his CV? Even though he's scattered, everything he's doing is implementation science. So I looked at him and said, what is implementation science? And they all started laughing at me. But that's where I decided to say, whoa, they say I'm an implementation science, and what I've been doing is implementation science. I decided to learn more. So I went back to my institution and I tried to see what is implementation science? How can you write proposals there? How can you use it? How can you do all the things that you've been hearing in this meeting? And that's where I was. Remember, 100% clinician trying to implement programs, trying to do them in an effective way to improve care for his patients. So one of the people I met along the way was Dr. Gedebe, who is a professor at NYU. At the time, I have never really seen a funded NIH project. And he was the first person who gave me his NIH project and said, this is how you arrange your thought. This is how you present your thought. This is how you design studies. And I put it in front of me. And I guess the rest of my career was well on the path to me, allowing me be able to be a clinician, be able to become a researcher, ask the questions that I needed to ask, get the answers I needed to ask, and go back to improving the care for my patients. So I'm going to turn back exactly to the next 10 minutes and spend a little bit on the main question that I learned is that when I wanted to implement things in Africa and when I went to Nigeria to implement my first NIH grant, one of the biggest things I have was how do I select, how do I adapt, and how do I tailor implementation strategies? I'm not going to go into the details of implementation strategies, but what I wanted to define here was for you to understand again that implementation strategies are the actions we take to enhance adoption, implementation, and sustainability of evidence-based intervention. That the evidence-based intervention are the procedures, the practices, the programs, the policies that have already been demonstrated to improve health outcomes. So we are not trying to prove that the evidence-based intervention works. What we are trying to do is to say what implementation strategies can we use to enhance the adoption, implementation, and sustainability of those evidence-based interventions. And what you're going to find out is implementation strategies can be single strategies, and they can be bundle of strategies, or they can be blended multiple strategies. And you will see this a lot throughout the presentation. And what I wanted to show you is that these 9 clusters of implementation strategies, that you are already using them. There is only one thing that I want you to remember when you look at this 19. Don't get overwhelmed by, don't try to look at them as something that are alien. Think about them. These are something that you're already doing. And I'm going to show you an example to show you that you are already doing this in your practice as a clinician, in your practice as a public health practitioner, and in your practice as a researcher. But there is one problem that I found out when I went to Nigeria to implement project, that I didn't do the 3 things that was very important. And that was that I have to name the implementation strategy that I want to use. I have to define it, and I have to specify it. So those were the 3 main things that was lacking. And that's one of the things I want to talk a little bit about today, that when you look at these clusters, and I'll go through the example of them to see some of the things you want to do. So take a look, something that says a strategy being developed stakeholder interrelationship. It sounds very, research-like. It sounds like something as a researcher, how do I have time to do it? But you look at that, you see that what example of it is that you have to build a coalition. And you already know that even if you want to convince a patient to do something that you want them to do, you have to be a coalition with the parent. If you are a pediatrician, then not only do you have to build a coalition with your pediatric patient, you have to build a coalition with the mother, you have to build a coalition with the grandmother, who is also part of the child's environment. So building a coalition is something that you already do as a clinician, and as a researcher, you even find out it's even very important. So developing that stakeholder interrelationship, think about it as building a coalition of stakeholder, people who are necessary for the intervention strategy that I'm trying to pick, for it to work, for it to be adopted, and for it to be sustained. Look at the second one, train and educate stakeholders. We know that very well. We develop educational materials for our patients. Either we develop them in a way we give them as pamphlet, we do them in terms of training where we have workshops, or we talk about it with them. So these are things that you are already doing. But remember, again, you have to name it, you have to define it, and you have to specify it. So if you look at the third one, use evaluative and interactive strategies. Sounds something that you haven't been doing. But basically, you're saying, I'm assessing for readiness, I'm identifying barriers, I'm identifying facilitators. The same thing that you do. If you're going to talk to a patient who have cervical cancer, for example, you want to tell them, you want to see, are they ready for treatment? What are going to be the barriers to their treatment? What are going to be the facilitators to their treatment? Do they have somebody who can take them to the hospital? Do they have somebody who can bring them back? Are they ready to go through the chemotherapy, the radiotherapy, or any other thing that may be associated? So these are things that you are already doing. Just remember those 3 things. Name it, define it, specify it. Adapt and tailor to context. So again, you're trying to promote adaptability. You have heard that throughout this conference, that context matter. So no matter what the intervention strategy is, you have to pick, adapt, and tailor it to the context where you're practicing so you can get the outcome that you desire. Then the 5th one is the support clinicians. It's something that you already do, because when you are working with people, if you are one time, you have a guideline for cancer control, you're trying to implement it in a country or in a state, you have to know that you have to relay this information to support the oncologists, the radiologists, the gynecologists, all the people who will be involved in this cancer control program. You want them to understand what the standard of therapy is. You want them to understand what is available. You want them to understand how to use those things. The reason I'm giving this example is for you to see again that these are things that you are already doing. You just want to be able to clarify them very well, specify them so you can communicate, so that when you share what you have done for others to take place, they can see, understand the things that you have done very well. So you want to provide interactive assistance to local tech. Everybody knows that. That's one of the things you see. If you look at the HIV program and the PEPFAR program, we have senior technical advisor, all of those things, trying to have people who can help locally to guide the programs, to guide the government, the policymakers, to guide implementing partners, to guide the clinicians at the site, so that they can actually put this program the way that it was intended. Then you say engage consumers. Well, you have to prepare your patient like we discussed before. The consumers have to be active participants. They have to be involved in their care. And some of those things are the things you do, so that when you pick implementation strategies and they say engage the consumers, you have to remember you are already doing them. So look at them from the point of the things you're already doing and be able to select those things. We talked about utilize financial strategy. Sometimes you're altering the incentive. Sometimes you are developing disincentive. And these are things you try in every way. When people come to me and said, "What, Doc, why should I get the HPV vaccine? I heard that you only have to give it to people who are sexually active, and my daughter is not sexually active. And I think by giving them the HPV vaccine, I'm trying to introduce them to become sexually active." These are questions you hear from your patient. And you're trying to talk about it. You try to anticipate them. You try to discover them. And sometimes you find out that use of financial incentive can be a strategy that you use to say, okay, if you're getting this vaccine, this happened. And sometimes you find out those financial strategies are where you say, if you go and get this vaccine, these vaccines are free. Sometimes it is that if you get these vaccines, you'll be allowed to enroll in school, which are some school mandates that work for vaccines. So these are some of the things. Financial incentive can be altered in a way that you can either alter the incentive itself or develop disincentive. And the last thing that I wanted to talk about in terms of the cluster is to change the infrastructure. One of the things you can understand, to remember that while you cannot go from every local environment to every local environment, you can start a dissemination organization. That is one of the change infrastructure you can do, where programs come together and you're able to share what has worked for the programs, what has not worked. What it does is that people do not have to go the pathway of what has not worked in the environment that they are. They can say, oh, they tried this in my environment, it didn't work, so I don't have to go that pathway. I can start this pathway, or to say, this is what they did in their environment, it worked for them very well, and their environment is the same like mine, so I can do that. So starting a dissemination organization is something that is a strategy that you can also do. So what I did is to pick one example from the 9 clusters that you can see Watts and the Byron Powell read out in the ERIC strategies that they did. What they did in 2015 was to look at all these strategies that was really in different areas, are being used by different people in different ways. They put together a lot of implementation scientists to really do the things that we are trying to do, which is to name these implementation strategies, to define them very well. So when you look at the ERIC basic strategies, which is one of the papers that was shared to you for this conference, you will see something that is very important. They listed 73 different strategies. One of the things you see there that I like very well about it is that they took the time to define each of those strategies, so that when you look at the definition, then it allows you to help you to say, what I am doing, can I name it? And you look at the definition and say, wow, what I'm trying to do fits into this definition, and this is the name of the strategy that is used. That becomes where you are going to communicate what you did and what outcome that it led to. So that is one of the things that I find that article that you're going to have that lists the ERIC strategies. It's not just the listing, it's a definition that will help you in terms of naming the strategy that you are going to use. So when you now have an idea that say, okay, from that ERIC basic strategy, I have selected the things that I think fits into my environment, that I want to be able to know, how can I select all of them that I'm going to use for this, my particular project, and which one of them that will work for me, and which one of them that I will use for this project I'm going to do. There are 4 ways. And Proctor listed this out, and the group is find out as concept mapping, group model building, co-joint analysis, intervention mapping. I've used 2 of these very well. One of them I've used for a long time was concept mapping, but along the way, I just see about intervention mapping and the steps that were so clear to me in a way that I can use it to select, tailor my intervention to the particular problem that I have at hand, and also to the particular environment. So I'm going to spend time, just the last 10 minutes of the time or less than that, to talk about intervention mapping. And then not ignoring the other concepts that are there, but to use it as one example of the methods that you can use to improve selection and tailoring of intervention. So one of these things you see that the intervention mapping draws upon the mixed method research, the theory environment, the stakeholder input, and the systematic process for intervention development. And then the step 1 is what we all already do, which is the need assessment. You want to be able to do a need assessment so you can identify those contextual barriers, that you can identify those contextual promoters, so that you are clear about those things. Then you want to be able to go to the and look at the program objective. What is it that you want to achieve? So for example, in cancer screening, you want to increase the screening for cancer. That's one of the things you want to do. You want to improve the management of the screen positive. That's one of the things you want to do. You want to facilitate access, and also you want to optimize treatment. So you say, okay, these are the 4 program objectives we want to see in cancer control. So you have those objectives there. You already have your need assessment of what could be the barriers and what could be the facilitators to these things. So in doing those stakeholder analysis, you are very specific about them. Remember, you are coming to those places that you now find out what those problems are, what those facilitators could be, and you have your program objective. Then you now go back to those ERIC strategies. I like them a lot, especially because I don't like to invent the wheel. If it's already there, I can take it, I can modify it, I can now use it. So when I go to that, back to that ERIC process, I go down each of those 9 clusters. And then each of those 9 clusters, I'm looking at them and I'm looking at the definition. So one of the things I want to do, what is it? What is it named? And I select them. And once I generate them, then I start matching those implementation strategies that I select. I'm matching them to the barriers that I want to overcome, and say, with this approach, with this strategy, overcome this barrier. And then I start to match them. And once I begin to match them, then I begin to refine them, tailoring them to the environment. For example, you said, well, I want to go out in the community. I want to use community strategy to go and engage people to give them vaccine, or to talk about increase awareness about vaccination. Then that environment, that community strategy differs from places to places. I can tell you, in Nigeria, for example, that if you're talking about community strategy, no matter what you think, there are 2 big communities that you're not going to forget. One of them is school. That you go to school, it is one place you're going to have a captive audience. You can increase awareness in school. The second place, what about those who don't go to school? One of the places in Nigeria for community strategies become the church or the mosque, the religious institutions. Nigeria is ranked #1 in church attendance in the world. It doesn't make them very great people, but what it does, that it has a place for you where you can actually reach people. And one of the things about the church is that people keep going to the same church that my grandfather went to, my father went to, that I go to when I grew up. So you can find people there, you can refine them there when they are lost to follow up. So you can find out that using a community strategy can mean different things for different environments. So you want to be able to make sure that you select the implementation strategy, you match it to the barriers that you think, and you make sure that it's also going to lead you to a program objective. Then once you have done all of these things, then you begin to operationalize those strategies that you have. And what you end up producing is that you have both the implementation strategies and the tools that you need to evaluate the effectiveness of the implementation strategy. Remember, you're not trying to evaluate the evidence-based intervention, for example, the secondary cancer prevention, where you're doing an inspection and you're doing on-site treatment. That has been shown to work. That is not what you're trying to do. What you're trying to do here is to select strategy that will help you make programs adaptive. You're trying to integrate this cancer screening into existing HIV program. What you're trying to do is not to see whether this secondary prevention strategy, evidence-based intervention, is already been shown to work. What you are trying to do, what strategy do I need to integrate this secondary prevention for cervical cancer into existing HIV programs, which already exist in all the parts of the country? So you want to say, how can I use the infrastructure there? How can I get this to those who are doing HIV care? Because we know that cervical cancer is most common in people with HIV. So how can I get them to adopt this evidence-based intervention, screen the women, improve access for them to get treatment, facilitate the management of screen positive, and optimize the treatment that these people receive? So these are the things that you want to do as you now go ahead to implement this, and then you monitor and evaluate them. So I think this is really, I hope that in this 3 things that I'm able to have told you the 3 things that I wanted at the beginning, which is to tell you my implementation story as a clinician, and give you hope that all the frameworks, all the things that you've heard about today, that some of them you already know. What you have to know is that you have to name them, you have to define them, you have to specify them. That way you are able to communicate what you're doing in Kenya, what you're doing in Tanzania, what you're doing in Nigeria with the world, so that people can learn from the success of what you have done and be able to replicate it in their own environment. The last thing I wanted to talk about is just to have a strong on-the-ground alliance. In Nigeria, we realized in 2015 the problem we had, because PEPFAR was funding a lot of the HIV program, but then people are being funded to do something that already been proved to not work in Nigeria. And I asked people, why are you doing that? Well, they gave us the money to do it, so what do we don't have a say. And I'm like, well, what kind of waste of money is that? So one of the things we asked NIH Fogarty Institute to do was to start with us, the Nigerian Implementation Science Alliance. And what we did, that we brought in all the main implementing partners together. And for the past 5 years, or 7 years now, because this started in 2014, we were trying to bring all of them together annually to share experience on their implementation. What have you implemented that worked? Why did it work for you? Can we learn from it? What have you implemented that didn't work? Why didn't it work? Can we learn from it? And these are the very strong Grand Alliance that we have in Nigeria. And we have all come here, we've learned so much, to the extent now that this organization is saying that they're going to establish centers, model centers. So we picked 21 sites in Nigeria that we call the Model HIV Comprehensive Program. The whole idea is to use this site to enhance, to put new ideas, test new ideas, and then from there, if it works, to scale it up. So these 5 organizations are implementing partners supported by the US PEPFAR program that actually provide care to all the 36 states in Nigeria for people living with HIV. So if you are going to integrate cervical cancer screening into HIV program, you are going to be working with them. Either you're working with one of them or you're working with all of them. And by working with all of them, they cover the whole state, and you can pick those 12 sites they have done. Nigeria is made up of 6 geopolitical regions, and they were picked from each of the region because context matters. They wanted an input from the stakeholders in each of these regions so that the actual thing that they come out with will help the nation in rolling out this integration of cervical program into HIV programs. When that is done on these 2 sites, you can find out that these programs can now take those model sites and replicate that and scale that up across all their programs, in which case you'll be covering programs across the 36 states. So I hope that I have done something to tell you my story, that you now like it.
Thank you very much. Thank you very much, Dr. Echezana. We are very grateful for your presentation. Thank you very much. So if we have questions, we can drop our questions in the chat box. The presenter will be there to answer our questions. Dr. Eni, I know you're on ground. I'm switching over to the next moderator, and that's Dr. Eni Kaneji.
Thank you so much, Dr. Oladeyebo. We've had some terrific speakers, won't you all agree? And the thing is, we still have some more to come. In the interest of time, we're behind, so I'll try to go straight to the point. So our next session will really focus on implementation science study design. So we'll have a great speaker to talk to us on that. Right following that, we'll go back to breakout sessions too. Dr. Paddy will come and set the stage for us. And then I want to reiterate, when we go to breakout session 2, please return to the same breakout session that you attended for breakout session 1. So that's what's on tap. We have, again, some great sessions yet to come. And our next speaker, Dr. Donna Shelley, will be talking about implementation science design while she's putting up her slides. Let me do a quick introduction while she's putting up her slides. She's a professor and director of the Global Center for Implementation Science at New York University School of Global Public Health. Her research interest is focused in the areas of tobacco control, policy research, implementation science, with a specific focus on studying healthcare system change to improve the quality of tobacco use treatment across a wide range of healthcare settings. Dr. Shelley, you have the floor.
Thank you so much. And you guys are all probably exhausted, but great talks. Some of what I was going to say has been said, so maybe I can skip through a couple of those slides. Thank you so much for including me in this wonderful conference. I'm coming to you, as you can see, from New York. This is the NYU campus and the famous Washington Square Arch. So this is just the 3 bullet points that I'm going to cover. And I just included the link in the bottom that I think was on the list of resources you have, and I would highly recommend taking a look at that. Thank you to whoever found that and put that on the list, because it's a really important resource for study design and development. So just to go over some of the characteristics very briefly, because I know we've talked about this, of D&I research. And the reason to just note it again is because it has real implications for study design selection and choices. The focus on context and the fact that we are focused also on understanding the complexity, as others have said, we embrace complexity in implementation research. We don't run away from it. But that creates challenges too, in terms of having to study and measure changes at multiple levels. This is a very stakeholder engaged process, if we've heard, and implementation research designs should have practical goals. They want to produce relevant data. They're real world. We want to try and actually accelerate the timeline and getting the results to the people who need them. Our goal is to produce generalizable data to be able to scale and sustain strategies and interventions. And we use multiple methods in our study designs, and the methods generally fit the purpose. And that's part of the pragmatism of this field in sort of considering trade-offs between some of these items I listed below. I wanted to, before I go into designs, and I wanted to just stop for a second and talk about quality improvement versus implementation science, as well as evaluation versus implementation science. And why am I doing this? Because I get a lot of questions about this actually from colleagues who do quality improvement and improvement science in my healthcare system and others. So I just want to point out that quality improvement emerged for a different reason in some ways. It came about to improve quality. Not that we are not, implementation research is about quality as well, but specifically to improve quality, value, safety, equity, and clinical outcomes. While implementation research and science emerged to improve implementation of evidence-based interventions. And the bullets that follow sort of follow that rationale in terms of the reason for quality improvement and for implementation research. One of the things though that's happening, and it's great that it is, because there's a lot to learn from quality improvement, in particular their use of rapid cycle improvement designs. And I'm going to talk about that towards the end when I talk about the designs themselves. However, we have something obviously to add to quality improve the work that our quality improvement colleagues do in terms of applying theory to driving the selection of strategies, thinking about organizational assessments to understand readiness, and expanding measures to include process and outcome measures in addition to clinical outcomes. So what about program evaluation? And so those of you who sort of got a master's on the way to where you are now may have been trained in program evaluation. And the questions that program evaluation asks are also the questions that implementation research studies ask as well. We do formative work and to understand barriers and facilitators, but the rationale is slightly different in the sense that we're looking to understand barriers and facilitators that will drive the identification and design of strategies to overcome those. Process evaluation historically is focused primarily on fidelity as an implementation outcome, while we are broaden the definition of implementation outcomes. And of course, both are interested in understanding effectiveness and economic evaluation. So as we've talked about already today, what does implementation science add to quality improvement, process evaluation, and prior research designs is the focus on context, adaptation, sustainability, and the rest of these items. What it adds in addition, though, is this concept of hybrid designs, which I will describe. And I think this is an important contribution of implementation research designs. And also implementation science studies define a clear implementation research question. And maybe that sounds like a funny thing to add here, but again, one of the most common questions I get is, what is an implementation research question? Well, Ann Rossich, who's joining us today as well, answered that question in this paper and gave us some guidance there with her colleagues. And you'll notice that the word strategy is sprinkled throughout these bullet points. And that's because a lot of that is sort of the differentiation really in terms of what an implementation study is trying to understand and test. So some of the questions here are, what would be the most feasible and effective strategies to reduce risk of breast cancer? What are some of the feasible and cost-effective strategies for early detection diagnosis, as well as looking at different system level interventions and strategies to improve the delivery of guideline concordant treatment. So let's go to the study designs then. So that's sort of the framing of sort of some of the things that inform these different study designs. What's really important to note is that these aren't new, these aren't specific to implementation research. These are typical study designs that folks in lots of disciplines and lots of fields use. But I think it's important to take advantage of these different designs, depending again on some of the questions I'll raise in terms of choosing which ones you're going to use. And I'll try and get through some of them. And then we're going to talk at the end a little bit about mixed methods and qualitative data collection. So you have to start at the beginning, and that is really with the problem. A problem is oftentimes easier to state than the question. And the problem might be, you know, HPV vaccine is lagging, uptake is lagging. Well, what's the research question? The research question might be, what are the strategies that we need to test to increase uptake of the HPV vaccine? How will you design the study to answer that question? What are the outcomes that you're going to measure? And what are the methods that you will use to collect that data? When asked, you know, how do I select a study design? That's another common question. Unfortunately, the answer is it depends. It depends on a lot of different factors. And these are just some of them, probably most of them, starting again with the research question, but the context. And I think, again, we've covered some of these considerations throughout the morning that need to be considered, but also, you know, stakeholders have certain requirements. Maybe you can't assign an exposure. There might be ethical issues. Maybe there's not the appropriate data sources. And I'll show you some examples of where that can happen, where you can't do an interrupted time series or a stepwise design because you don't have the kinds of data sources that you need to do that. So one of the ways I've used to sort of help me select a study design is to go back to a framework. And you've already just learned about the Consolidated Framework for Implementation Research. Many of you already knew about this framework. I use this framework a lot. And I present it actually as a nested framework because individuals are influenced by the inner setting that they're part of, as well as the outer setting. And so, you know, when I was working in Vietnam, we spent almost 2 years using the CFR framework, doing interviews with stakeholders and trying to understand the context for implementing tobacco use treatment in Vietnam. What was the unit of randomization going to be, or the unit of analysis? Were we going to do a systems integration process? Or were we going to do individual designs to try and see whether tobacco use treatment interventions work in this population? And so it's one of the ways that you could think about using to answer some of the questions that I posed in the previous slide, which is, you know, what are the resource constraints? What does key stakeholders think needs to be done? What are the priorities in sort of deciding what to do? And of course, integrating a framework, preferably a determinants framework, or frameworks, as we saw, into your study design. I just wanted to show this. Ooh, wait, what just happened? Sorry, just because I think it's a good mental model for thinking about implementation research designs, as well as just to say, again, the what we've heard about, the how are you doing these strategies, to reiterate that I have the barriers up there with the bar overlapping those two to remind us that strategy should be influenced by theory, and what we hear on the ground are the barriers. And then, of course, the implementation outcomes we need to select as part of our study design, and determine what effectiveness is defined as or looks like. I'm just going to add this one, and then we'll go to the designs. But because I really love this work, J.D. Smith has published a great paper, and you should. I actually included the link. What I like about this is that I like logic models, and you know, I got a master's in public health and first learned about logic models there. Logic models are about inputs, activities, outputs, and outcomes. And what J.D. Smith did was actually adapt a logic model to implementation science. And what I look at this as is sort of a helpful planning tool, taking everything we've learned today and saying, okay, I need to develop a study design. Well, I also need to map out the components of that. I need to map out what I've learned are the barriers, how those barriers of facilitators or contextual determinants. And you see the CFR domains on the left, influence uptake of the intervention, how those are going to inform the choice of strategies, what we think the theory of change is, what's the mechanism by which those strategies work. And we really need to, that's one of the key reasons for applying theory, is so that we can replicate our findings, because we know how and why it worked, and then the outcomes. So I just filled in a little bit of these boxes. I've been using this in some of my work. It's actually really helpful to present your findings to colleagues and stakeholders, because it's easy to understand. So what about study designs? So effectiveness and implementation are different. And just in the purest form I'm showing you here, before we talk about hybrids, they're testing an intervention versus an implementation strategy. The unit of randomization is different. The unit of analysis is different. And the outcome focus is different, of course, the health outcome and effectiveness. And sometimes implementation trials may not even study the implementation outcome or the clinical outcome, because you're so confident that your intervention works. However, you may be working in a different population or a different setting, and you may want to make sure that, in fact, that something that was shown to be effective in intervention, like tobacco use treatment intervention, that was shown to be effective in a high-income country, is actually as effective in a new population and a new context. But this is the effectiveness versus implementation. So what's a hybrid design? Again, I think this is an important contribution of implementation science research. It basically is trying to address the lag in the timeline, which David talked about, in translating research into practice and policy and programs. And the type 1 doesn't just test intervention effectiveness. Now we're gathering data also on context for implementation. Why not use the opportunity to do so? Usually using qualitative data, but can use quantitative data collection as well. Type 2 is looking at both intervention effectiveness and at the same time starting to think about the feasibility and impact, preliminary impact maybe, of implementation strategies. And type 3 is looking at the effectiveness of implementation strategies and gathering data on clinical outcomes associated with implementation. So let's talk about experimental designs. And hybrid designs are oftentimes conducted as experimental designs. This is sort of a, oh, there's something missing there. A parallel, this is a pragmatic trial, which doesn't have a control, but is comparing two implementation strategies. The unit of randomization is sort of a healthcare setting. It could be a community, it could be a healthcare district, it could be a province. It's working at that system. The implementation strategy is trying to change that program delivery system, or and the outcome is adoption of the evidence-based intervention. So this is a study that I finished a couple of years ago, which was a cluster randomized controlled trial, which is a type 3, because it's comparing two different implementation strategies, with the outcome being, the primary outcome being provider adoption of best practices for treating tobacco use, and the secondary being clinical. I wanted to show the two boxes on the left and the right, because most of these studies, oftentimes they include, especially when you're transferring evidence that was created or emerged from studies in one context to another. And in this case, we were implementing an evidence-based intervention and strategies that were shown to be effective in the US and other high-income countries. And so we did an extensive formative evaluation guided by CFR to understand what the context was for implementation, and to adapt both the intervention and the implementation strategies. Aim 2 was the RCT, and we looked at fidelity. And Aim 3, we did a post-interpretive assessment, meaning that we used CFR again to do qualitative interviews with providers and patients and stakeholders to understand what worked and what didn't, to help us interpret the quantitative findings, and to also ask questions about the potential for sustainability and scale up. Just to say, because I just showed you how I use qualitative methods, and others often do around an RCT, I just added this here, but I will mention qualitative methods again briefly at the end. And what's the rationale for doing this? I just described it really, which is, again, to inform modifications and strategy selection, to adapt measures too as well, because we're oftentimes trying to adapt. We lack validated measures in these contexts. And afterwards, gathering that information about how and why it worked, explain variation maybe across sites, and I'm sorry, and examining sort of the underlying theory and generating additional hypotheses. So what other randomized designs are there besides that, the classic sort of two-arm parallel design? There's the cluster randomized design, which allows you to look at within and between site comparisons. And here you're taking a cluster. Again, it could be a community, it could be a healthcare district, it could be community health workers, it could be a site, and you are randomizing when they actually get the strategy. There's some advantages and disadvantages to this design. I'm going to show you the design of one I did in the US. One of the pluses is that everybody gets the implementation strategy. In this case was practice facilitation to improve uptake of tobacco use treatment guidelines. But you need retrospective data. So you needed to be able to generate data pre, during, and post at regular intervals. And this was quarterly. It's nice because you do get to look at sustainability. So it's most appropriate when you're making decisions about rolling out something, an implementation strategy across a whole healthcare system or perhaps a whole area. But there are challenges. There might be changes in policies or practices during this time period, and sites that roll in later might be affected by that. And so that's one of the drawbacks. It's also, again, challenging. We wanted to do this in Vietnam. And in fact, we couldn't do it because we had no retrospective data on tobacco use treatment in the clinics that we were randomizing. And so we had to take a different pragmatic approach, which was we were randomizing 26 sites. Each site was, sites were randomized into one or the other implementation strategy. And we actually did the study in waves to address that. That causes its own challenges because, again, the sites come in later. They're not randomized into when the clusters get the implementation strategy. And so you have to deal again with those secular trends. And our biostatistician was able to deal with that. It basically addressed the issue around trying to implement in multiple sites, which can be at the same time, which can be quite costly. So this is an option. And I actually provided the reference for Ken Scher and Brian Weiner's study. This is a protocol for their SIA scale-up study, which is using a step wedge design. So really worth looking at that design. What about quasi-experimental designs? Why do them? Because sometimes, as I said, randomized experiments are not either practical or ethical. The external validity or generalizability is better than RCTs because they're real world, but you can lose that ability to make a causal inferences. Why not? Again, the internal validity issue. But these are very important designs to apply to your work, and they have a lot of use, in particular, I think, in implementation research. I wanted to show this because I think this is interesting because it's a non-randomized hybrid type 1 design. People always think about, I think, hybrid designs as being randomized only, but this was a study, and it's not a cancer-related study, it's an antenatal care study where the government did not want to randomize. And so they basically took these village clusters, an intervention one and a comparison one, and they did a pre-post population-based survey to look at birth outcomes. And the intervention was in the intervention clusters, CHW home visits with this group process, group visits with peers versus the home visit alone. And what was interesting about this design was that they took, they selected a group of women enrolled into a nest and put them in a nested cohort to do a smaller study, which was more cost effective than trying to do this across everybody, and looked post intervention qualitatively and quantitatively at acceptability of the intervention, and spoke to also the CHWs and the group leaders to understand sort of what were some of the barriers to implementing this enhanced strategy or intervention, and to increase and then basically to inform the further adaptation and scale up of the design. So you can do sort of a hybrid, and the hybrid component of this is an effectiveness study looking at these two different interventions with the collection of data, qualitative and quantitative data at this point to understand the context for implementation. This is another quasi-experimental design. Again, more useful if you're looking at policy changes. You need multiple data collection time points. So you need to be able to collect data at multiple times over time. Usually you can also, though, have a control. So if you're implementing, let's say, a healthcare coverage package in one province and you have another province where in fact that's not being implemented and you're able to collect data on access and health outcomes, you can have a time series analysis that at least has a control. And then this is a really important also design, this pre-post with insight design. If you're rolling out a new evidence-based guideline, like a colon cancer screening program, and you're finding that in fact patients aren't getting the kits or they're not completing the kits and mailing them back, you might want to do some qualitative work to understand why, talk to patients, talk to providers, and develop a strategy on site, and then do a pre-post. What happened after the strategy came into place? And again, like the interrupted time series, you can strengthen this kind of design by adding a control. You'd want to purposefully select another clinic that has somewhat similar characteristics in terms of number of staff, patient population, et cetera, and systems in place. But that is a reasonable and pragmatic way to simply assess trying to enhance implementation of a particular guideline that you're trying to implement in your setting or a group of settings. So finally, I want to talk about Plan, Do, Study, Act design. And this is where we borrow from quality improvement. And I think David showed this concept actually in one of his slides on sustainability and scale up. And what implementation research is adding, I think, to this design is the use of a conceptual framework to guide this planning process. And so the plan part is defining objectives. What are your questions? What are the outcomes that you expect? And what strategies based on the needs assessment make the most sense? What outcome measures are you going to use? And then you have to define very, very clearly the who, what, where, and when. And Enola Proctor also published a really nice paper on actually defining strategies very specifically. Who's the target? What's the justification for it? All those questions of who, what, when, where. And then you do it. And then you put that strategy in place and then you study it. And then you may do multiple cycles until you feel as a group that you've got it right, that you're getting uptake and implementation of the intervention that you're interested in improving uptake of. There was actually, what's interesting about this design is that it was done to be really just, as I said, a quality improvement design. But in fact, I've seen multiple studies now that are using this as an implementation strategy itself. So using PDSA cycles as a strategy for implementing an evidence-based intervention. And I really like that idea. I think it's an interesting approach. And this is an example of a study that did that. I think the SIA study too, I don't know whether Ken would agree with me, is somewhat like that. The approach is really that systems analysis approach, kind of takes practices through this design. And so you can randomize sites or use a quasi-experimental design that use a PDSA cycle versus not, to see how that approach works to enhance implementation. And finally, this really great paper by Barker talks about using PDSA cycles to scale evidence-based interventions, and talks about this idea of developing a scalable unit. And so testing in one site and then spreading it and testing to another site and scaling up until you can go full scale. Again, I highly recommend reading that paper. They actually, the case studies that he includes are all studies that were conducted in Africa. So just another approach or way of looking at this kind of implementation strategy or process. I know you've heard about a lot of frameworks, but since we're talking about PDSA cycles and adaptation, one of the things that's sort of embedded in a PDSA cycle is this idea of modifying. And this is something that Sturman created, and I like this framework because it's just really what it is it's nothing, it's really powerful and important, but it's basically like most frameworks, is like all frameworks, it's a guide to you. It's going to help you remember which questions to ask. And the more defined, the more clarity you have around what modifications you made, again, the more likely you'll be able to replicate the modified intervention. You'll understand what worked and what didn't work. And it'll inform further scale up of the intervention and the implementation strategies. So when did the modification occur? You know, what level? What was the nature of it? And she recently expanded, she and colleagues recently expanded the frame to include the reasons. You know, why did we have to modify it here? Maybe those reasons don't apply in a different setting and you wouldn't have to modify it in that way. But important to, again, if you're using something like a PDSA cycle particularly, but also we've used this during our process assessments and outcome assessments to understand, you know, fidelity and fidelity, you know, implementation research. Again, one of the key characteristics of the designs is not just looking at fidelity, but also looking at adaptation. And that's really where this emerged from. I'm talking about in the context of the PDSA, but I wanted to back up and just explain that that is really where, again, implementation research differs from program evaluation, for example, in thinking very prospectively and proactively about, you know, not only fidelity, but what adaptations are necessary to actually achieve the same outcomes that were achieved in the efficacy study or effectiveness study. Qualitative methods I mentioned. I just wanted to mention one thing about analysis. Qualitative methods can be quite intimidating. They seem like they take a long time. You got a lot of data on your hands. It requires group process of reading transcripts, coding them. So I would recommend that you look at Hamilton's presentation here and read about rapid qualitative analysis. I've used this process twice recently with our new study in Vietnam, where we did a formative assessment to inform our adaptations to the implementation strategies and intervention. And we didn't have a lot of time. And I don't have time to explain how this is done. This is that's a whole nother talk, but worth taking a look at and seeing whether it would be more feasible to do qualitative research if you were able to apply that kind of approach. And again, qualitative research is so important in implementation research to define these hard to measure barriers in facilitators. We don't always have those the survey tools. And understanding and identifying processes we don't even know exist, and answering, of course, the why and the how. And I'll end with just a comment about mixed methods, which is not just using quantitative, qualitative, but the a priori approach to thinking about how you're going to use the quantitative and qualitative data, how you're going to integrate them, connect them, and use them to add to the analysis of the outcomes of interest. And there are different ways of doing mixed methods. You can collect quantitative and qualitative data concurrently at the same time to sort of confirm the findings from each source of data. You might want to do it sequentially, which is oftentimes how I've used this approach. Is we have the quantitative data and now we want to do the qualitative assessment to understand the why and the how and why something worked or why it failed. And then there's the approach of just embedding qualitative data analysis to enhance a sort of a larger quantitative study design. And again, lots of resources to learn more about this approach. And I'll just end with that. An example of this idea of embedding a qualitative data analysis. So this is a study that we are doing in New York City, where we're evaluating the implementation of the smoke-free housing policy. And this is a national federal law now that all public housing has to go smoke-free. We're doing actually a natural experiment, looking over time, different time points at exposure to secondhand smoke. And embedded in that quantitative analysis is this process assessment that's guided by CFR. And I'm using J.D. Smith's framework to show you a way that I presented the data to our stakeholders. The pluses mean facilitators, the minuses are barriers, but we used the qualitative data we collected from smokers and non-smokers and stakeholders and staff to understand what the barriers were to implementing that process, that policy. and have been working with our stakeholders to develop strategies that specifically address those determinants. So this is, again, this qualitative assessment was embedded inside this larger quantitative data collection process. So you have a lot of choices. Work through the process of ranking designs based on the variables we discussed. Do some formative work to understand what the stakeholder preferences are, what the, as I said, constraints are. You can do it formally or informally using a framework or not. But getting to that question, answering that question of what design I use does depend on a lot of these different issues. Gather qualitative data and use frameworks to help guide your assessments across multi-level contextual domains. I think I'll end there. Thanks. Sorry if I talk too fast.
Well, thank you so much, Dr. Shelley, for that very practical talk on the implementation science study designs. The one question I saw in the chat box, participants were curious to know if you'd be willing to share your slides.
Oh, of course, yes,
okay.
I will.
Excellent, excellent. So thank you so much. Well, in the interest of time, we'll have Dr. Gila Anita come introduce to us what we'll be doing in the next breakout session. After she does that introduction, we'll take about a 10-minute break. When we come back, we'll go back to our respective breakout sessions. So where you were prior during breakout session 1, please make sure you go back to that same breakout session. Dr. Nita.
Thank you, Ernie. And yeah, thank you all for those fantastic presentations. One quick question for the organizers. Will it be possible to keep, I'm going to share the slide that summarizes what we'll be doing in the breakout groups. Is there any way for that slide to be available to the breakout groups, should it be useful? Walk through what we're hoping to do during the next breakout. And essentially, as Dr. Gravitt mentioned in her presentation and at the start of the first breakout, really ideally, we're hoping to see that we realize a lot of material has been covered. We don't expect it to be fully digested and have you all be able to easily apply it at the ready necessarily, but to explore these sort of key questions and applying these implementation science approaches that Drs. Ramaswamy Ezenoluwe, and apologies if I mispronounced that, and Dr. Shelley have just covered in terms of the use of theories and frameworks, identifying and developing strategies, and applying study designs. So in the same 3 breakouts that you were assigned in for the first time, although there may be some mix-up, I'm not sure if everybody will still go to the same breakout, but essentially, whatever this set of interventions or intervention is that you're thinking about, those implementation challenges and how might you design a study to address those challenges. Here are some questions on the right side that you can see we encourage you to think about. So pulling from Dr. Ramaswamy's talk about theories and frameworks, what might be, how might theories and frameworks inform, what are the key implementation outcomes you would seek to affect through a study to address implementation of an intervention? What are potential implementation barriers and how might you think about what those might be based on some of the theories and frameworks the field has? And also thinking about what would be critical processes to consider as you are attending to those barriers and developing those strategies. And so in the next talk, we heard a range of ways to engage key stakeholders and use different approaches in implementation science to identify strategies to overcome barriers. And so thinking about how you might do that as well. And finally, and Donna, your talk was so rich, covering the broad range of study designs, which, you know, after 8 years of being in the field, I'm still digesting. But so I don't think there's any expectation, while each of you are familiar with the study designs that you use, applying it to an implementation challenge and what might actually be feasible given your study question. Would it be feasible to randomize? To what degree can you manipulate? So thinking about, and also how might you, what might be the need for a combination of qualitative and quantitative methods and how could those potentially be integrated? There was a comment in the chat about the feasibility of mixed methods. So exploring that as well. So whatever, so these are the questions that we've laid out in hopes that you can consider in the 55 minutes you all will be together. If you have any questions about this, feel free to ask.